ఒకసారి అర్కల భాస్కర్ సార్ కాల్ చేయరా సార్ నా కాల్ లిఫ్ట్ చేయలేదు ఇందాక భాస్కర్ సార్ has joined.
I spoke to him.
Sir is here. I think I'm just going to change the setting there so that there is minimal disturbance. We're also live on YouTube now. Morning everyone, namaste and welcome to today's event. Today's event is the release of IAP for the month of February, and we also have a pediatric pulmonology symposium, and a very warm welcome to all the attendees. Thank you for joining in on a Sunday morning, and a warm welcome also to our guest of honor today, Dr. Ramesh sir, the President of Indian Academy of Pediatrics. Thank you, sir. Thank you for gracing the occasion despite your busy schedule. And we convey regards on behalf of Twin Cities branch and also the Telangana state. No, in our everyday work, we often tend patients, and you always look forward to something that gives you that little excitement, that little joy of being in a small position wherein you can contribute something to the society and also the organization. And the journal is a wonderful opportunity, and the entire journal committee, along with inputs from the seniors, we have undertaken a small task of coming up with a journal every month. And for those who put it together, it's like a painting. And when it finally takes shape, it's as I go through all the articles, as I screen them, as I get it designed, it's such a joy to finally see it happen. And big thanks to all who have been involved in it. I'll now invite Dr. Sunkoj Bhaskar, our President IAP Twin Cities branch, for his remarks. Over to you, Dr. Bhaskar, sir.
Yeah, thank you, Dr. RFP. Respected President, Dr. Ramesh ji, our Vice President, Central Zone, Central IAP, Dr. Radhakrishna ji, our President PATS, Dr. Arakala Bhaskar, Editor-in-Chief, Dr. Sanjay Sriram, my dear Central IAP EB members, Dr. Sri Sailam, Dr. Vijay Kumar, Dr. Sri Krishna, distinguished faculty members, dear colleagues, ladies and gentlemen, good morning all, and welcome you all to this second symposium of our IAP Twin Cities branch. Last month, we did on genetics. Now we are doing it on pulmonology because we know the importance of respiratory disorders in our practice. Day in, day out, we see a lot of outpatients, and as well we have too many inpatients. And secondly, still it is one of the leading causes of infant mortality rate under 5. And as well, so many new entities are creeping into this respiratory issues like sleeping disorders. And my special thanks to our faculty members, Dr. N.K. Subramanya. He doesn't need much introduction. He was the president of IAP Respiratory Chapter 2021. And I say he's the face of the Respiratory Chapter of Indian Academy of Pediatrics last year and this year. And he's a darling of IAP members of Telangana state, because we used to have a lot of interaction with him. He had presented many guest lectures. And Dr. Indu Khosla, whom I know since last 2 to 3 decades, but she doesn't know me, because we know leaders, but they don't know people like ordinary person like me. But I have a lot of respect for her beautiful presentations. And I think she's a busy endoscopist, and as well her main interest is in sleep disorders. Dr. Suma Shivalan, He's a rising star of pediatric pulmonology. Whenever I see him, I remember his dad, Dr. Somu. I still remember we attended his, when he was in limelight, we attended the Pediatric Respiratory Conference at Bangalore. He used to carry one noise-making this thing in his hand, and whenever he presses, that slide changer has to change the slide. And he used to cover its topic within a given period of the given specified time. He's such a great man. My respects to him. And Dr. Razia, as you all know, she's an asset to Hyderabad. She's an American board certified pulmonologist working at Apollo. Thank you, Dr. Razia Madam, for accepting our invitation at the last minute. And Dr. Deen Dayal ji is an eminent otolaryngologist, an astute clinician, a good teacher, and highly rated and respected academician in ENT fraternity. And he had recently authored a book on management of snoring and sleep apnea disorders, which I had gone through, and I'm thankful to him. He had sent me the soft copy. I think all of us should go through that book. And lastly, he was 1 year senior to me at Gandhi. He moved from Kakatiya to Gandhi. And he was 1 year senior to me. He was in the last semester of final year. We were in the first semester of final year. That time also, he used to teach us general medicine, general surgery, OBG, and pediatrics. He's such an intelligent person. It's a privilege for me to have him here. And the architects of the symposium are Dr. Suman and Srinivas Jekka. Really, they had put in a lot of efforts in organizing the symposium. I'm thankful to them. The entire credit goes to them. And Dr. Suman, he does, being a very busy practitioner, he has a lot of interest in allergy, asthma, and immunology. And Dr. Srinivas Jekka, ever since he came to Hyderabad, he's very much involved in respiratory disorders academic activities. He keeps sharing interesting cases in different social media, and is another one of the very few pediatric pulmonary endoscopists. So once again, it's a President Sir, Dr. Ramesh ji, it's a honor to entire IAPTCB and Telangana state for gracing this occasion. We are grateful to you and thankful to you for accepting our invitation, despite your busy schedule in another city in Kerala. Probably you're traveled or you're traveling. Thank you so much. Once again, thank you all once again, and wishing you a great academic experience. Thank you.
Thank you, Bhaskar sir. Now I invite the President of IAP State, Telangana State, Dr. Arkal Bhaskar sir, to please share his remarks. Bhaskar sir.
Good morning all. On behalf of Pediatric Academy of Telangana State, I congratulate all the editorial staff headed by Editor-in-Chief Dr. Sanjay Sir for bringing out this e-journal. And also I congratulate the entire team of IAPTCB for conducting the second symposium on concept-wise like respiratory problems in pediatrics. And as time is very less, I once again, my good wishes to all the participants and welcome to all the elite panelists and speakers. Thank you.
Thank you, Bhaskar sir. Request Dr. Sanjay Sriram sir, the editor-in-chief of our journal, to please share his thoughts. Sanjay sir, please.
Good morning, all of you. There are two important reasons why I am very pleased today. Number one, yesterday was Vasanta Panchami. We had all done puja for Saraswati. And today we have a symposium on pediatric pulmonology. Number two is I am amongst so many friends actually whom I have known since the last 3 decades. It's pleasure to see Dr. Ramesh as the president. Thank you, Ramesh, for sparing your Sunday morning. It's pleasure to see Radha as the vice president. Morning, Radha. Thank you for joining. My good friends in the respiratory chapters, Siva, Indu, and Subbu, for being here. We had just inaugurated the respiratory chapter about 3 weeks back. Dr. Bhaskar, both the Bhaskars, Bhaskar of Twin Cities and Bhaskar of the state chapter and RSV. Honorable executive members, my students, Dr. Yashwant, Dr. Vijay, Dr. Srisailam, good morning to all of you. Wish you all the best. God bless you. Now, I'm reminded of a story of the bamboo seed, you know. The bamboo seed once planted takes about 5 years time for a shoot to come out. And once the shoot comes out, it takes about 15 years for us to just look up and see how tall the bamboo tree has grown. So the seed for this journal was started about 6 to 7 years back when Sudarshan was there amongst us and he was the editor-in-chief. I know how much passion he had towards the journal, and he had named it as the Touch Journal of Twin Cities IAP. It was my dream that the journal should be entirely digital. And I'm fortunate that I have RSV along with me, who has been given the total liberty to design it the way he feels fit. And RSV is a digital man for all of us. Srikant is there. Dr. Srinivas is there. Dr. Shabbir is there. We have a huge committee, and we are looking forward that the journal will be one of the reputable journals all over India. We are also looking up for 2 shoots to come up. We have a very nice designed website which has gone live, but which still needs some fine tuning. Probably in the next 1 or 2 years, we will see that as we are having virtual symposiums, our website will be one of the most visited websites. And we have an app for the Twin Cities. We have already designed the app. The shoot has come out and the tree has to crawl forward. The tree has to climb up. So with these few words, I wish the journal a huge success. And I wish this Pediatric Pulmonology Symposium will have some concrete take-home messages. I forgot to mention Subbu, my very close friend. Thank you, Subbu, for joining on Sunday morning. Subbu, you are more virtual than physical and present everywhere, omnipresent. With these few words, thank you so much. God bless.
Thank you, Sanjay sir. Request our Central Zone Vice President, Dr. Radhakrishna sir, to say a few words, please. Sir, unmute chestunara? Yeah, go ahead.
EB and OB, first of all, President, Indian Academy of Pediatrics, Dr. Ramesh sir, EB and OP of IAP Telangana and Twin Cities branch, Editor-in-Chief Sanjay, and other dignitaries. It is indeed a pleasure to join today's journal release. It's the 2nd volume. I really appreciate it. Somebody asked me many years ago, who is an academician? And the answer was very clear. A person who does research is an academician. But in a country like ours, where we hardly have any research except in micro pockets, the other alternative is CMEs. Between CMEs and genuine research, we have another level of academics, namely publishing journals. So today, Telangana State and Twin Cities are proud. I can say they can be proud enough that they have certain level of academics in the form of CMEs and journals. A big, heartful wishes to the team of IAP Telangana and Twin Cities branch. Thank you.
Thank you, sir. And thank you, everyone, right from the editor's team till the Vice President for your constant encouragement. This is what gives us the energy to continue to strive further. Now it's our honor and our privilege to have amidst us the President of Indian Academy of Pediatrics, Dr. Ramesh Kumar, sir. Sir, we are requesting you officially release the issue. Over to you, sir.
Thank you, my dear Sri Krishna. President, Twin Cities branch, Dr. Sungoj Bhaskar. Vice President of Central IAP, my dear Dr. Radhakrishna. President Patch, Dr. Arkala Bhaskar. Editor-in-Chief of the journal and our senior academician, stalwart of Central IAP, Dr. Sanjay Sriram, Secretary, Dr. Sri Krishna, Twin Cities Branch, Treasurer, Dr. Vamshi, President-elect, Dr. Lakshman, and immediate past president, my dear Dr. Arjun, and my dear executive board members of the Central IAP front representing PATS, Dr. Vijay Kumar, Dr. Sri Krishna, as well as Dr. C. Shailam, Dr. K.V. Rao sir, and other stalwarts of from Twin Cities branch as well as from Telangana. A great morning here when we are here for the second monthly CME from Twin Cities branch, and where we have to release our journal too. And I'm so privileged that Twin Cities branch is keeping its reputation high, as always, on the academic domain, as well as on the organizational domain of Indian Academy of Pediatrics. And Hyderabad has always been a medical hub across the country. It has become the knowledge hub for Indian Academy of Pediatrics. And with so many stalwarts around, right from the earlier days of Dr. Mathur, and later on the late, our respected Dr. Sudarshan Reddy, and now and later on the baton was there to Dr. Sanjay Sriram, Dr. Ajay Kumar, and other seniors, Dr. Rao, and now the younger lot, the digital man, Dr. Sri Krishna, and both the Paskars around, Dr. Arkala Paskar and Dr. Sungoch Paskar, and Dr. Yashwant and others, Dr. Surendranath, Dr. Yashwant, who have been leading TCB in the past and who are there with the family benefit scheme, our pet project, welfare project. And with across the state, you have got Dr. Vijay Kumar as well as Dr. C. Shailam and other senior, Dr. Lakshman, and all seniors to take you through. And it's a great going for TCB on all aspects. I'm sure that this journal dedicated to pulmonology, this CME dedicated to pulmonology with all the key stalwarts in pulmonology around with the chapter chairperson, Dr. Subramania, Dr. Shivalan, Dr. Indu Kosle, Dr. Rasia, as well as all the stalwarts, and the topics have been well chosen. It is a great day of pulmonology CME in the offing. And pulmonology is one which always cannot be satiated at any moment. The knowledge is still coming up. The practical tips are coming up to any moment. I'm sure Dr. Subramania has got a lot to offer. Dr. Indu is there. So however said and done, whenever we practice, we have some tips from the senior stalwarts, senior practitioners, and that makes a more comforting and more rewarding on the practice front. So I'm sure today's pulmonary CME will always be enriching to the practitioners. At the same time, you had a journal coming up last month on genetics, and this month, the journal has got a very interesting article from Omicron from Dr. Naveen Thakkar. I was just going through that, Naveen Thakkar sir. So it's all on all fronts. It's great going for the Twin Cities branch and Hyderabad, and I really wanted to be there with you on your installation on Jan first week. But it could not happen because of the Omicron and other aspects. But I'm sure I will be able to catch up with you at an early moment with the other. We are having a lot of activities coming up, maybe starting with Pedicon, March, sometime around second week of March. So a lot of activities will be there. I'm sure I'll be around with you all to have some academics at the same time, more of camaraderie being shared on our platform. And it's my great pleasure to have the journal going on this platform, the second issue of your your journal CME, and I request, and once again my congratulations to all the academicians at Twin Cities branch and Telangana PATS for coming out with this wonderful CME activities as well as the journal, and keeping the academy on the toes and arranging excellent activities. And I wish the very best time for you in the year 2022. And at Central IAP all too, we have got a lot of activities coming up. And we request all-hearted participation from the team at PATS as well as the Twin Cities branch for the activities. And I wish a great time of learning for all my dear friends. And it's the time now for the journal to be officially released. I request Dr. Srikrishna to proceed with the digital release of the journal. Thank you very much and have a great Sunday.
Thank you, Ramesh, sir. And thank you for releasing the IAPTCB journal. This is issue 222. And I'll quickly run through the issue. I'll just take a minute, not more. To the board and the ED. We have from our editor-in-chief, the president, and the secretary. And these are the contents. So we have a special article, and the lead article is by the president of IPA, Dr. Naveen Thakkar sir, and he spoke about the COVID-19 vaccination. And we also have the science statement by IPA in support of COVID vaccination for children. Then all about Omicron, what we need to know by Dr. Sanjay Sriram. Omicron, this is the WHO's technical brief by Dr. Suresh Kumar, who is our EB and myself. One article on recurrent respiratory infection. We trained to join the hospital on just with Dr. practice by and we have BLS for COVID, and this is as latest as just last week, wherein specific guidance has come up along with an algorithm on of COVID by Dr. Srisalam, our PEP member, and then two case presentations we had in the case, clinical meetings of IAPTCB, a case of recurrent diarrhea with Dr. Srinivas Kalyani, Dr. Preet swelling on the neck diagnosis by Dr. Nirmala, Dr. and Dr. Varshita from Nilofer Hospital. Detailed case presentation along with the diagnostics. Postgraduate by Dr. Apar. This is the brief of the this is the poster which we had released as Government of India opened up vaccination. Yeah, I'm so sorry that got disconnected. So that's all. Hand it over to Dr. K.V. Rao and Dr. Suman to please take over from here to conduct the pediatric pulmonology CME. And our many thanks once again to Ramesh Kumar sir. Sir, it gives us a lot of energy and motivation to have you on stage with us. Wish we could actually call you to Hyderabad and have this at a wonderful place in Hyderabad, but we definitely will call you and look forward to your presence at Hyderabad soon. So that concludes the initial for a little time delay. Hand it over to Dr. K.V. Rao and Dr. Suman to take it forward. Over to you, Dr. K.V. Rao.
Yeah, good morning, everybody. It's a pleasant Sunday. First of all, I would like to thank Dr. Bhaskar Garu and Dr. RSV for giving me this opportunity as a moderator. And thank you, everybody. It's been a pleasant Sunday to have wonderful session of important aspects regarding pulmonology, and eminent speakers are there. And we have every session of 20 minutes of 6 sessions. Starting with the severe pneumonia by Dr. Subramaniam, and functional breathing disorders by Dr. Srinivas Jekka, and latent tuberculosis in children by Dr. Somu Garu, and sleep disorders by Dr. Indu, and obstructive sleep apneas by eminent Dr. Deen Dayal Garu. And after that, we have challenging cases and interesting session later on. I invite Dr. Subramaniam Garu to take over the session regarding complicated severe pneumonias. Sir, can you please put on the first slide, please. Can you share your slides, sir? Dr. Subramaniam Garu. Good morning, Dr. Subramaniam Garu.
Is it visible?
Yes,
sir.
yeah,
It's full screen now?
yes. Thank you, sir. So, good morning, sir. Good morning. Welcome, sir. Dr. Subramanian Garu is eminent pulmonologist and professor in pediatrics at Bangalore. Sir, kindly go ahead, sir.
Yeah. KV Rao sir, just let me know 2 to 3 minutes earlier when I have to close 20 minutes from now.
Yes,
Please.
yes, sir.
Please,
Sure.
remind me.
Sure. Yes, sir.
My dear friends, the senior most, the first citizen of IAP, Dr. Ramesh Kumar, the first citizen of Telangana, Dr. Bhaskar, and my mentor, Dr. Sanjay Sriram, and all the teachers. If in Telangana, if I start taking the names of my friends, that itself will be 20 minutes. So my apologies to all my friends. So many of you who have been affectionate and passionate, being associated with me for years. Let us go through the journey of severe complicated pneumonia in just 15-20 minutes as a bird's eye view, how we shall go about it. Remember, pneumonia is something that would generally respond. There will be reasons not to respond. I think this is a topic which will also be otherwise synonymous with what if antibiotics fail when I start in a day or two, and what to do. Or this is also a topic which would just cover what if it is progressive and non-resolving as expected clinical course of events. So let's just see through the journey of how the pneumonia worsens, progresses, or gets complicated and doesn't listen to our antibiotics or our lines of management. Now, if you take pneumonia as the cause of death, this is the leading cause of death and is a killer. I don't want to tell you the killer story of pneumonia, but I wanted to ask you a question. What is that kills a pneumonia child? Is it pneumonia itself, or is it that we have got severe pneumonias that are the killer? And if you look at all the mortalities, this is now the leading cause of death, and what is responsible for the mortality is severe pneumonia. Please understand that pneumonia don't die. It's the severe pneumonias that die. Again, it is the complications associated with pneumonia that is cause of death. So therefore, can I oversimplify and tell you that pneumonia is not the cause of death? It is the severe pneumonia and complicated pneumonias that are the causes of death. So that narrows down my topic of importance, and taking the focus entirely on these two categories, severe or complicated. A line from me is that sometimes increasing severity and addition of complications cannot be separated in practice. For example, see, a pneumonia getting on to having an empyema can be considered as a progress or worsening severity, or it can also be considered as a complication. Did you understand? So there is often an overlap between increasing severity and appearance of complications. So therefore, when I'm going to proceed further, there is going to be some kind of overlap. Now let us look at what are the symptoms and signs by which I can recognize a child as worsening, progressing, increasing in severity, or getting into complications. These are the ones. Sir, this is a complicated slide. How should I remember? Pretty simple. You have two categories, infants and children. And all that you need to focus here is the last line, that is SpO2. Please remember that pulse ox should be there in everybody's clinic, and it should become most, I would say, fifth sign. We can go ahead and tell it should be the first sign the pediatrician should just do. Just take a pulse ox reading. If anybody has got SpO2 less than 92, that means he is hypoxic. Now, if you ask me who is the killer in pneumonia, is pneumonia the killer, severe pneumonia the killer? I will tell you further dissecting, telling that hypoxia is the killer. So it's very, very important that the mortality is straight away related to hypoxia. And what you see upstairs above this SpO2 in the table, they are all the signs and symptoms of hypoxia. Be it tachypnea, be it nasal flare, be it recession, they are all the compensatory and compensatory mechanisms that would combat hypoxia. And if they decompensate, there will be respiratory failure and death. I think I made the message very clear. And how do I remember this? Severe the fever, more the tachypnea. You remember the age cutoffs for tachypnea. If it is 20 more than, roughly, this is a thumb rule, 20 more than the age cutoffs, that means you are progressing to severe pneumonia. Let's say 50 is the cutoff for the age, and now it is 70. That means the child is probably going to go for decompensation. Am I done with this simple concept? Even counting the rate, taking the pulse ox readings, or recognizing all these nasal flares, grunt, apnea, cyanosis, so on and so forth. Now let's see what could be some of the complications that you see in pneumonias. They can be pulmonary complications or extrapulmonary complications. Extrapulmonary complications are in the form of dissemination, and pulmonary complications are often local and related to the nature of the organism. It could be empyema, necrotizing pneumonia, it could be paranemonic effusion, pneumatoceles, lung abscess, ARDS, so on and so forth. And we have seen all these complications in our life. Now, how do I recognize these complications? And why should we? This is simply because once a pneumonia child becomes complicated, there is uncertainty related to etiology, diagnosis, management, prognosis, and deterioration is also uncertain. So this makes it for us very, very important to recognize the complications. Is it common? It's very common. See, it is not that the pneumonias don't progress. Nearly 1/5 to 1/3 of them may slowly progress to complications, depending on the etiological factors, host factors, so on and so forth. I have just presented you a couple of epidemiological data to support my postulation that, that it is not that every pneumonia will respond, and you will have at least 10 to 20% of them who would behave or misbehave. Is etiology of our organisms are same as pneumonia, or in severe and complicated organisms are different? I think one thing that will suddenly strike to you is Staphylococcus. Do you agree? It is not necessarily Staphylococcus. Even the same organisms like strep pneumonia can also get complicated. Viruses can get complicated. Remember, there are host of even, for example, chickenpox, so on and so forth. It's always important for you to recognize that many of these organisms can be a reason for etiology of severe pneumonia. Please understand. Let me just take you through this case. 3-year-old child, toddler with chest pain, high fever, and difficulty in breathing. What is important for us to see is that his saturation is 90%, and there is a rapid progress. Now, within a day, this 3-year-old toddler has worsened. What does that mean? So you can anticipate severity or complications in him. That's all I wanted to see. Please look at the progress of the pneumonia. So therefore, be on the line. Now, if you analyze the symptoms of this child, pulmonary, extrapulmonary, etc., you have chest pain and localization that takes it to a probable, a plural origin of complications. And therefore, you should anticipate whenever you have pneumonia, which is progressing, and you have localization in the form of chest pain, please, your antenna should go up to look for effusion. You should not wait for chest X-ray or for ultrasound to tell you. So therefore, this is very, very important for me. Now, what next I should do? If you find a fluid, non-invasive should take over the invasive investigations, and therefore I would prefer an ultrasound. Ultrasound is a very added value tool nowadays. You can get anything and everything on an ultrasound. See, those of you who have not done ultrasound of the chest, start doing them. Please ask for that. Now they have got a newborn TCB chapter of pulmonology. You can arrange a workshop on ultrasound, and we can be of some resource for you. And there are many in the respiratory chapter who are already doing ultrasound of the chest. So this is very, very important. You can recognize pneumonia, you can recognize complications, you can recognize the fluid, you can recognize the septations. And this is far, far better than even the CT. And I'll tell you, ultrasound should be used more. This is very, very important for us. So therefore, our after confirming the fluid, we will rule out multicystic or septations, and then you go for tapping the fluid for analysis. You have got an algorithm for management of empyema, and for which I am not going to spend too much of time, but I wanted to tell you one important concept. What is that is paranemonic effusion and what is that is empyema? This is a very, very common question that is there in the minds of many pediatricians, and I will tell you a simple answer. As long as the fluid in the pleura is an exudate of pneumonia in the lung, this is paranemonic effusion. It is sterile. It is an exudate, but sterile, doesn't contain organisms. Did you understand? Now, the issue is that these are nothing but tears of the lungs into the pleura. The lung weeps into the pleural cavity and the fluid is sterile, like your tears, and gets collected in the pleural cavity. Now, this is called as paranemonic effusion and is sometimes going to exist with many pneumonias. This is to be watched for if it is going to develop into or is an empyema but mistaken as paranemonic effusion. How do I know? Now, if these tears in the pleural cavity, or I would say exudate in the pleural cavity, gets infected, then what happens? And naturally, there is going to be formation of pus. And whatever the glucose, proteins that are there in the exudate is being used by the organisms for its growth. Now we have got two pathologies. Tell me what are the two pathologies? One in the lungs, that is infection. Second in the pleura, that is empyema. So empyema is nothing but the second septic focus apart from pneumonia. Now, therefore, when you get an empyema, you must be very cautious because you are dealing with two things. One is infection, second is the pus collection, which has to be drained. Now, did you understand the overall management of empyema, why it should be drained? It is because it is a pus. And this is not a simple exudate. How do I differentiate whether it is a simple exudate, that is paranemonic effusion, or a complicated exudate, that is by growth of organisms called empyema? You cannot go for imagings, except that when you have multiloculated effusion, of course, it is obvious that there is organization. Otherwise, you have to do synthesis. And diagnostic tapping is the only way you can differentiate, and there will be fall of pH and reduction of glucose. Why that happens? That is because the organism is growing in the pleural cavity. Therefore, it consumes the glucose and there will be acidic environment. Is that clear for you? So pH and reduction of the glucose are the most consistent biochemical findings after pleural fluid analysis that will make you to differentiate paranemonic effusion from that of empyema. Now further, what will you do now if the child is running fever? You are not going to do anything else, but you are going to act upon this. Now you have to do imaging and find out what has happened. Now see here in this particular child, you can see this is just a CT which is done. You need not have to do CT for every effusion that you are doing, but what I am trying to show you is just for you to watch. Look at the collection. So therapeutic choices for us is thoracocentesis, and after synthesis is done, if it is confirmed empyema, it has to be tried. You are going to put a chest tube in situ for a couple of weeks till the drainage of the pus completely is done with. Now you need to give appropriate antibiotic. Now if the pus is thick or if there is organization that is happening, see this empyema passes through some phases. Initially there is exudation, then there is infection, then there is fibrin, then there is organization, then there is it forms thick septations, it becomes more solidified, then gets fibrosed. Did you understand? So it's all the process of inflammation and organization that happens in an empyema, and very, very important for you not to allow the steps to progress further. That is why I told you severe or complicated pneumonia, your antenna should be up to recognize the complications. This is very, very important for me. So what are the antibiotics that have to be covered? You have to add coverage for Staphylococcus, remembering whether it is MRSA or MSSA. This is the summary of empyema. You may end up doing fibrinolytics and then VATS, or directly VATS if it is multicystic, or if you can ask the help of your pediatric surgeon who is available to you and discuss and have a multidisciplinary approach to the management. Second case, I'm not going to discuss more, but except that I wanted to tell you, this is a 2-year-old who is low on Santile's curve. He's malnourished. So what happens in a malnourished child is the disease is going to progress, and this is the X-ray where, you know, like the last child, let me tell you, I'm cutting it short for you. There was rapid progress. We did USG thorax, we did thoracostomy, everything child was started but did not respond. Why it doesn't respond? Because of host factors. What will happen if the host factors are like immunocompromised, malnourished, etc.? I'm giving an example. What happens is that we cannot continue with the same antibiotics, have the same kind of approach. This is when you have to ask for CT. So therefore, non-resolution of fever following an empyema treatment, or if not empyema, otherwise progressive pneumonia, you are going to look for necrotizing pneumonia. Necrotizing pneumonia is nothing but liquefaction of the parenchyma. Mind you, this is not possible to diagnose only clinically. It is only by imaging. It's a radiological diagnosis, and you see the areas of necrosis on the CT. So that is exactly what should be done. Therefore, it is patchy necrosis and areas of low attenuation on CT that you would see. Either CT or even ultrasound at times can pick up, but CT is better than ultrasound for evaluation of lung parenchyma. So necrotizing pneumonias do occur. They can get into further complications like bronchopleural fistula, empyema, respiratory failure, shock. You know, it's basically completely damaged, liquefied, necrotic lung within the living lung. Please understand, sometimes you may have to end up surgically, sacrificing the lobe as well. So this is very, very important. This can happen because of staph, MRSA, etc. It's very, very important for us to know this particular strain of Staphylococcus, which can be responsible. And these are the evidences to say that you have MRSA. You know, sometimes it will never hide. You can easily make out the progression, and some of the conditions can be responsible for necrotizing pneumonia. In a short slide, I have given you the summary of how you can, what are the predisposing factors, how do you recognize, investigate, and manage. There is a lot of difficulty in managing necrotizing pneumonia. It needs intensive care management, supportive care, multidisciplinary approach, higher antibiotics, prolonged antibiotics, plus or minus surgical interventions that are required. So I am going to go to the last case, where I wanted to tell you that this is an 18-month-old toddler progressed, and this is the X-ray. This is nothing but an abscess which needs to be conserved, and often we don't drain a lung abscess like we drain an empyema. We need to be very, very cautious. At times it can break and cause pneumothorax. It can cause many other complications which can happen, and you need to manage with thoracostomy, tube drainage. There can be other complications like ARDS. There can be complications like thromboembolism that can happen in pneumonia, especially if it is a mycoplasma pneumonia. You can have SIADH, can have hematological issues like hemolytic uremic syndrome, hemophagocytic syndrome, embolization, etc. I'm coming to lastly the summary that if you get a community acquired pneumonia, you need to be asking one question: is it a simple, uncomplicated pneumonia, or I should triage them into intensive care, operative care, or rehabilitative care, etc. after assessment? That is very, very important for me. Please remember, if you think an X-ray is not required, if you think a CBC is not required, if you think a CRP is not required, if you think a blood culture is not required, it means that you are dealing with an uncomplicated, non-severe pneumonia, and amoxicillin is enough. You have to think beyond amoxicillin, beyond antibiotics, more aggressive supportive care, more multidisciplinary approach, more involvement of surgeon, radiologists, referral centers, etc. If it is a complicated pneumonia, you don't have much time there. The disease can progress rapidly, and your antibiotics may not be working. So please be very, very careful in choosing appropriate line of management and investigations. In summary, whenever you think ambulatory care is not enough, you need intensive care and more aggressive clinical approach And that is what is the summary of management of pneumonia and pneumonia with complications. I would just appeal to all of you, please recognize the complications as early as possible. And how do I can do that? It is only by one, at upfront if the child is sick and severe. Second, if the child progresses faster. Third, if the child is not listening to the antibiotics. Fourth, if you think that the time frame of events or sequence of events, clinical deterioration that is happening is out of expectations. There could be complications to complications. What I meant was there could be empyema and complications of empyema. So once worsening is there, please be careful. These are the children who are going to kick the bucket. And it is the severe pneumonia or complicated pneumonia that is cause of morbidity and mortality and causes of death in pneumonia. Other pneumonias do not die. So please do not allow any child to die. It's ultimately the clinician, not the investigations, who is responsible for prevention of morbidity and mortality. If there are any questions, I would be happy to take.
Since there are 2-3 minutes time, I request the participants to raise your questions in person. I'm sorry, you can come in and you can ask some questions. 2-3 minutes time is still there.
Yeah, I saved some time for questions, and I had to rush through the management of empyema in 2 or 3 lines. I think there will be lot of doubts and controversies, but I have suppressed all of them for want of discussion. If there are any questions, I would be happy to take up.
If somebody has any question, please raise your hand. We will unmute you and you can ask directly. Yeah.
Fine. Sir Anand, sir, please.
Sir, Dr. Ramesh, sir, thank you very much for your enlightening this complicated pneumonia. I wanted to know, at present scenario, most of the local practitioners, they are using the antibiotics, higher antibiotics. What is the incidence of empyema in our pediatric population at present? Because everybody is using the cephalosporin groups, and at present, what is the percentage of the incidence, and how you will recognize the patient is toxic or something, intercostal edema, all those things will be there. And 20 years back, we used to see these cases, but at present, very few. And what is your experience of the incidence at present as a pulmonologist?
No, I have got plenty of galaxy of people like from Mumbai, Hindu, from down south, Sumu and Sanjay and yourself, sir, having different types of experiences as far as pneumonia is concerned. But I wanted to tell you 1 or 2 important things. I will give Karnataka for example. In south of Karnataka, if you see Bangalore and others, the prevalence of malnutrition is less. But if you go to North Karnataka, definitely prevalence of malnutrition is high. If you have malnutrition high, the progression and worsening. I'm just giving an example.
Okay.
So if you are living in an area where malnutrition is high and host factors like lack of immunization, prevention, hand hygiene, these are like, they look like community medicine lecture, but I think they are more important than our antibiotics. This is which we don't look in our day-to-day practice. The moment you get a child who is from this type of background, I would say within inverted commas, socio-medical background of red line, or below poverty line, or I would say below medical line, or I would say he is not in the line of not getting complications. These are the children whom you should straight away have high index of suspicion and watch for them, because these are the ones who are not going to come back to you for even asking for medical aid. So this is one. So if this is as far as the prevalence here can be double that of the prevalence elsewhere. Now in a urban practice, generally, the mothers are very sensitive. Pediatricians are going to little over-investigate. They may do ultrasound for just pneumonia, not even complications. And therefore, I would feel that somewhere they can recognize. This is where the host is not going to misbehave, not the pediatrician. It is the organism. In these situations, it is always either a virus, chickenpox, H1N1, or a nasty staphylococcus that is going to cheat the pediatrician as well as the mother. So I would just tell you that the kind of practice where you are staying is the one which is going to dictate the way the child is going to progress, because the organisms are ubiquitous. Please take both into consideration, organism and host factors. And lastly, let me tell you, environment. Is there smoking, overcrowding, etc., which pollutions? These also contribute for mortality. And we have to be thinking that every pneumonia is going to get complicated until otherwise we prevent it from getting complicated. We should not take anything easy just because it is from urban, just because somebody is even given pneumococcal vaccine. Don't think that pneumonias do not happen. It does happen even in the immunized. So therefore, we will never ever take any child for granted. I will tell you, a good clinician looking at the progress, monitoring and using pulse oximetry judiciously and looking at the child's face, it will tell itself whether it can have a cup of coffee or can sip a badam milk next day, or is not at all responding to you or listening to your antibiotic. This is most important. Response to therapy, not the fever. It is the general well-being of the child that's most important. Fevers can sometimes persist because inflammation and necrosis can continue, but not fever. Everybody is after fever. But most important is the appearance of the child and response of hypoxia. These are very, very important tools.
The Subbu sir, Dr. Indu has a question.
Thank you, sir. Thank you.
Thank you, Dr. Subramania, for your lucid talk and a very complicated topic to finish in 25-30 minutes. I think I would give you the credit for doing it. I wanted to make a comment, and I would request your comments on it. Since necrotizing pneumonia, a complication of pneumonia, can occur with a large number of pathogens, there is also sometimes dual pathogens, viral and bacteria on top. So I want you to comment on the role of respiratory biofire. Now it's very freely available. The cost is coming down on the role, and here we know that knowing the pathogen is extremely important in a necrotizing pneumonia because the child is critically sick. So role of respiratory biofire in children with necrotizing pneumonia.
Indu, you have put the fire in the topic. But what I wanted to tell you is that if I would look at an investigation which is going to cost somebody dearly. Very difficult to give a blanket answer across India where, mother has 100 rupees to 10,000 rupees in her pocket. So very difficult to give a blanket statement on biofire should be done or not to be done. This is one point number one. Point number two, does my line of management change after and before doing biofire? If it is not going to make any difference, then no. If there is an educated mother who wants to know and probably an inquisitive pediatrician or a research-minded pediatrician who wants to know what is happening in my city or in my practice or in my area, and I would like to know the pattern that is happening or worsening that is happening, very much welcome. I will never say no for an investigation. However, even if the biofire tells you some organisms, the kind of coverage that I am looking at necrotizing pneumonia is a blanket therapy and very aggressive therapy. This is where I won't be adding drugs to a failing regimen. See, this is where I would cover. See, for example, if I get a varicella pneumonia, which is necrotizing, or I will say H1N1, which is necrotizing, am I going to prevent that particular child from receiving anti-staphylococcal drugs? The answer is no. Anyway, I'm going to cover for anti-staphylococcal drugs. So if you ask me personally, it has not made any difference because my coverage would be same. I will be covering for staph. I will be covering for a host of organisms which are otherwise have to be done. So this escalation is mainly clinical, and you should not take one step at a time in necrotizing pneumonia. You should be rather taking 2-3 steps up and go up. Don't wait and then do. This is all that I wanted to tell you. I think I made my point clear. I would be negative on the biofire rather. but maybe looking at more aggressive coverage.
Yeah. So your point is well taken that we need to be aggressive in a necrotizing pneumonia, but in cases who are really sick and non-responsive, probably there is a definite clear role, but we must not misuse the biofire and get confused. That is, I think, what he's trying to say, and his point is well taken.
Thank you, Dr. Subramanian Garu, for wonderful presentation. And as a past IAP Respiratory Chapter President, I would like to thank you very much for this wonderful talk on this wonderful Sunday, sir. Thank you very much, sir. Any other queries? Please put it in the chat box. Shall we go ahead with the second session? I would like to invite Dr. Srinivas Jekka, sir. First slide, sir. First slide, please. Yeah, the slide before. First one, sir. So I would like to invite Dr. Srinivas Jekka. He is a introduction slide, sir, please. Previous slide, sir.
Sorry, sir, it's not moving.
Yeah, okay. Yeah. So everybody, good morning, everybody. Again, I would like to introduce Dr. Srinivas Jekka. It's a privilege to me introduce Dr. Srinivas, being a MRC PH and FRC CCH and Diploma in Allergy and Diploma in Nutrition and MD Pediatrics and Diploma in Sleep Medicine. He underwent training in Pediatrics, Pulmonology and Allergy in India as in the prestige universities in UK, and the clinical experience as international consultant in UK and Singapore, and the Indian experience at Rainbow Children's Hospital. And academics, he has undertaken research in pediatrics and pulmonology and severe national and international presentations and publications. It's an honor for us to have Dr. Srinivas Jekka today. Kindly go ahead, sir, regarding functional breathing disorders, sir. Thank you, sir.
Good morning, everyone. I would like to thank Dr. Bhaskar, sir, for giving me this opportunity, and also the IAP. When Dr. Bhaskar asked me to choose a topic, I chose this topic because since the onset of COVID pandemic, I have seen so many functional respiratory disorders, more than what I have seen in my career preceding the COVID pandemic. So I think this is a very hot topic. I know it's a difficult task to speak of to Dr. Subramania, but I'll try to make it as much interesting as possible with cases. So what we're going to discuss today, what are functional respiratory disorders? What is the relation between stress and breath? Can we classify them in any way? Or how do they present as practitioners? We want to know how do they present clinically? How can we diagnose? And it's a difficult, we don't have enough time to go to the entire management, but I'll just have an overview of management of the functional disorders. Right, let's look at functional respiratory disorders definition. Basically, they are conditions where there are respiratory symptoms in the absence of organic pathology. However, the symptoms should be persistent and there should be excess of what we expect from their physiological cause. For example, you have an asthmatic, but if his breathlessness is disproportionate to his asthma, that would be an excess. And they have a psychological triggers. So why should psychological trigger cause the breathing problem? Then we come to this, what is the relation between stress and breath? So, we have to go a little bit into philosophy or to know, we know a little bit about the brain, but our medical science hasn't touched up the concept of mind. What is mind? How does the mind work? How is it related to the brain? How does stress act on the body? How does stress act on the breath? What is the importance of breath? Can we use the breath to control the mind and the stress? Of course, the last two, the yogis have been using that to control the stress and help us. So, looking at the importance of breath, we can explain the importance of breath if you go to our yogic method of describing the human anatomy. It says that there are 5 layers of the body: the Annamaya Kosha, or the physical body that includes your brain. Then you have Pranamaya Kosha, or the breath, and then you have Manomaya Kosha, or the mind. So you see that the breath is a link between your body and the mind. And anything that affects your body, like you have physical illness, for example, you have body pain, severe body pain, then your breath is affected. Or if you have stress in your mind, your breath is affected. So anything that affects your body, physical body, or affects your mind can affect your breath. And of course, both stress and anxiety can increase your heart rate, can make you breathe faster, and it affects all organs of the body. And this is what we're realizing now every day. So is there a way we can classify functional breathing disorders? And there was an article by Dr. Anbar and Hall, it's actually a book, where they classified functional respiratory disorders into somatoform disorders, malingering, but it's actually a DSM classification, somatoform disorders, malingering, factitious disorders, and vocalitic disorders. So if you look at somatoform disorders, again, there are 4 types: conversion, somatization, pain disorder, and hypochondriasis. So conversion disorder is where there is a psychological conflict, and that psychological conflict will lead to a physical symptom. It serves 2 purposes. The primary gain is where the consciousness is taken away from the psychological trigger. The secondary gain is where the child gets sympathy from the family or doctors. And with this conversion disorder, the child is indifferent or is really not bothered by the problem. For example, we saw a teenager. So I would like people to type in what they think of the diagnosis in the chat box. I saw a teenager, so unfortunately subjected to sexual abuse, probably from a distant relative. And the child obviously is afraid of disclosing because of the social repercussions. Suddenly the child stopped to talk. She couldn't talk properly, and she was complaining of difficulty in breathing. So what do people think this child is having? So this child has, when I asked the child what's the problem, she was pointing to the throat. So this child had vocal cord dysfunction because of the underlying sexual abuse. Coming to next one, which is somatization disorder. These children complain of multiple symptoms which affect multiple organs. They may be seeing several specialists for that. In contrast to the previous condition, they seem to be really bothered by their problem. The common respiratory problems are cough, breathlessness, palpitations, and chest pain. Last month, I saw a teenage boy. He had a headache 2 years ago. So they saw pediatrician, pediatric neurologist, had a CT, MRI, and everything. It was cleared. 6 months later, he developed abdomen pain. Saw a pediatrician, pediatric surgeon, pediatric gastroenterologist, had an X-ray, ultrasound abdomen, CT abdomen. Again, that was cleared. Then he presented with chronic cough. So I would like to put the cough, request people to type in the box what you think is a diagnosis. Okay, I know this. So to add on to that, this child has a cough only during daytime. There is no cough at night time. So that is one of the clinching diagnoses. And this was a habit cough. So we'll come to that habit cough a bit later. Next is pain disorder. Pain disorder where there is significant pain in the absence of physical findings to the extent that they can cause physical disability. This is an interesting case of a 9-year-old child. This child came when we, 3 years ago, when we started DNB, taking DNB students in our hospital. So 9-year-old child came with severe chest pain, very anxious parents, had all the investigations like chest X-ray, ECG, echo, etc. So our DNB student who was fresh from medical school, he was very worried about this student. He was thinking about myocardial infarction, pulmonary embolism, and all the cause of chest pain he would see in his adult practice. So I was trying to reassure the student as well as the family. So to reassure the student and also myself, I gave normal saline. And the moment I gave normal saline, the child's pain disappeared. So that told me that it was a functional disorder. However, that same night, child again had pain, and our student gave intramuscular analgesia. And apparently the pain of the injection was so much that the child stopped complaining of pain. So that injection was actually therapeutic. So this was a pain disorder. Hypochondriasis, where there is an excessive fear of a serious illness despite lack of medical evidence. The parents as well as their As well as sometimes even the children may be preoccupied with the symptoms, and they may seek several doctors and they want a real clinical diagnosis. Again, I saw a 10-year-old male child. This is during the first COVID wave. He's a non-asthmatic, and the family have been watching news every day, day in and day out, about the COVID and COVID deaths and everything during the first wave. And the child was extremely worried that he will have COVID infection. And when he had this asthma attack and he had this cough, he was convinced that it was COVID. And the family did RT-PCR 3 times to convince the child that it's not COVID. And in the clinic, when he was there for 30 minutes, and during the 30 minutes, he was washing his hand with sanitizer 5 to 6 times. So he was so preoccupied with this diagnosis of COVID, and I had to reassure him a lot to make him understand that he hasn't got any COVID infection. So this is hypochondriasis. Malingering, where the patient feigns a symptom to avoid something. Okay, for example, I had a 12-year-old male child, non-asthmatic, and like many other teenagers, he's gained 15 kilos in the last 2 years during the lockdown. And because he's gained weight, I advised him that he have physical exercise. And now this child uses asthma and breathlessness as a way to avoid exercise because he's a little bit lazy. So this is malingering. Factitious disorder, fortunately, we don't see much in our country. You see, we used to see that case in the West, where the patients manufacture the evidence of a medical illness. It's also called Munchausen syndrome. And Munchausen syndrome by proxy is where the parent manufactures the evidence to show disease in their child. Again, fortunately, not very common. Vocalitic disorders are, again, they're more common. They can involve coughing, throat clearing, sniffing, grunting, screaming, barking, blowing, and sucking sounds. Transient tics are where they last less than 12 months, and chronic tics where they last more than 12 months. And Tourette's disorder, we all know, involves motor and vocal tics. So we have a 16-year-old child. He makes these noises every time he has an exam. So this child goes to his coaching institute where they have an exam every week. So 1 or 2 days before his has. So this is habitual throat clearing. So let's look at the common presentations, how this disorder is present. Broadly, you can classify them into cough syndromes and these disorders where dyspnea or breathlessness is the major symptom. In the cough syndromes, you have habit cough, habit throat clearing, paroxysmal sneezing. And in functional breathing disorders, you have vocal cord dysfunction and hyperventilation. Of course, you have other rarer causes as well. So we already discussed about habit cough. It's also called psychogenic or tick cough. Sometimes the child can have a viral illness with a wet cough, and after a week or so, it turns into a dry, barking or honking cough. And typically, it has a repetitive quality, predominantly during the awake period. And one of the diagnostic features is that there is no cough once the child sleeps. Contrary to medical causes like asthma or postnasal drip, where the cough is worse at night time, in habit cough, there is no cough once the child goes to sleep. All the investigations are normal, examination is normal, there is no response to treatment. So again, there can be different types of habit cough. The one I already, in case people didn't listen to the first time, this is the honking type of cough. Again, sometimes they may not be so severe, sometimes it can be softer quality as well. So this is next, vocal cord dysfunction, where the vocal cords close abnormally, and then again, vocal cord dysfunction can be spontaneous or induced by exercise. They can present with air hunger, breathlessness, tightness in their throat or chest, and an examination there can be stridor or expiratory sound. And treatment is speech therapy, where there is spontaneous vocal cord dysfunction, or ipratropium inhaler for exercise-induced vocal cord dysfunction. Hyperventilation syndrome, again, is very common, where there is an inappropriate rapid and deep breathing triggered by anxiety or stressful events. Sometimes it can be part of panic attacks. And then this hyperventilation causes respiratory alkalosis, CO2 washout, can cause hypocalcemia. Therefore, the child presents actually with lightheadedness, tingling, numbness, twitching, spasm, tetany, CNS symptoms like confusion, stupor, and coma as well in the worst scenarios. More common in children with asthma, diagnosis is based on the chronology of events. So the child becomes anxious, and then this anxiety leads to hyperventilation, and that leads to all the other symptoms as well. Normal examination and saturations and the blood gas may show respiratory alkalosis. Treatment is by reassurance and rebreathing into a bag. Interesting case we saw a few months ago, 9-year-old female girl brought with repeated attacks of breathlessness. The several investigations done, all were normal. So I interviewed the child separately, asked her why she's worried and anxious. Then she told me that she's seeing ghosts. And when she sees the ghost, she breathes faster. Then I asked her, where does she see the ghost? She said, I see the ghost on a tree beside my house. Then I asked her, why are you anxious in the hospital? Then she said she can see the ghost in the hospital as well. Now it is my turn to become anxious. So anyway, the father, who is a pujari, he solved the problem by tying an amulet or tayattu, what we call around the hand, and that reassured the child that it will protect her from the ghost, and then the symptom got better. So the reason I'm saying is, many times when you ask the parents, are there any triggers in the child's family or at school, they say no. Many times the parents absolutely say there's no problem with the child. Only when you sit with them in detail and ask them, they will say. And sometimes interviewing the child separately in the absence of parents, sometimes they'll give you the clue. And if there is no solution, then we have to refer them to a psychiatrist or psychologist. There can be functional dyspnea without hyperventilation as well. There can be a functional component of asthma. Studies have shown that up to 5% of asthmatics can have dysfunctional breathing. Reassurance. Habit sighing, again, is seen in some children where they take a deep breath and then breathe out as if they're sighing. Again, reassurance, it's a benign condition, just reassurance will do. So let's look at the diagnosis of functional respiratory disorders. So we discussed various conditions, but all of them, there's some patterns where we can suspect the functional respiratory disorders. The first and most important is absence of symptoms during sleep, or sometimes when the patient is distracted. So child is playing video games or doing something very interesting, you may not see the symptoms. Particular location or activity, for example, the child has breathing problem whenever he goes to school or whenever he does homework. Emotional component is there. There is some exposure to traumatic life event. Again, when we say traumatic life event, it doesn't need to be a big thing for kids. It could be just that there could be a difficult teacher at school. They could be having a fight with a friend, or they could be having parents who are very pushy. So these are all could be traumatic for the child. And then lack of response to medications. Investigations. Unfortunately, these children have a lot of investigations done before a diagnosis is made. But few things we can do are a blood count, look at pulse oximetry, chest X-ray, you can do a blood gas. And if things are not getting better, and when you refer to specialists, we can do spirometries, exercise provocation, bronchoscopy, and psychological assessment is an investigation as well as therapy as well in these children. And coming to management, which is my last part, when we look at in the overview of management, what are the challenges in managing these children? What are the principles and how to approach the management? How do we manage acute versus chronic? And suggestion therapy, if I have time, I'll go through that. The challenge in managers is the difficulty. They're very difficult to diagnose compared to organic disorders because we're comfortable with diagnosing organic disorders. Once you make a diagnosis, there's denial by the families. Very difficult for the family to accept a diagnosis of functional disorder. And unfortunately, once a diagnosis is done, the family loses trust in the doctor. And that is the reason, even though the doctors think that the child could have functional disorder, they are a bit afraid to give that diagnosis to the child. Unfortunately, these children have too many investigations and unnecessary treatments before a diagnosis is made. The parents can be frustrated and the treating doctors can be frustrated as well. Sometimes the patient's symptoms can be reinforced by the attention provided or the secondary gain. Financial incentives, not in our country, but in the West, where people get disability living allowances, etc., that itself can be incentive for ongoing symptoms. And secondary gain, as I already mentioned, there are two scenarios. One is where there are no related medical problems, but just functional problem. If you treat them with behavioral and psychological therapy, they get better. The second scenario is where there is a related medical disorder. For example, habit cough or hyperventilation in a child with asthma. These are more difficult to treat. We have to treat the underlying medical disorder as well as the psychological problem. And knowing when it is medical and when it is psychological is sometimes difficult to know. So how to approach these children? A detailed interview with the patient and family separately is very important. Offer reassurance that the symptoms are real. Sometimes we say, okay, there is nothing in the lungs, it's a problem with your brain. And once you say that, you have lost the family. And another way of telling it is saying that your cough started with a viral infection, and that's probably triggering or irritating your airways. And because it's irritating your airways, you're coughing more. And that cough itself triggers more cough. And you can tell that you have an opportunity to control your symptoms. You can control your symptoms yourself. Encourage the child. Deal with frustration. Refer to pulmonologist and also a mental health professional in difficult cases. Acute disorders are relatively easy to treat. Reassure them. Explain the cause of that, like I explained before. Treat the medical problem if any. Address the psychological problem and try to treat them. Self-regulation techniques can be taught by yourself or by psychologists. And refer to mental health specialist if you're not finding any progress with the treatment. Chronic disorders are more challenging, where you need more psychological input. Exclude medical cause by detailed history and a judicious use of investigations. Underline the word judicious use of investigations. Do not hesitate for second opinion. Treat the underlying psychological issues. Refer to mental health specialist earlier and follow the child carefully to prevent any relapse as well. So suggestion therapy, I have used this for many of my patients, particularly with habit cough, where the child is asked to focus on the doctor. Then we ask the child to become aware of the forthcoming cough. And then we ask the child to hold back the cough briefly. Either they can do it voluntarily or they can take a sip of water to suppress the cough. I mean, you can look at this website, habitcough.com, and there are also videos by Dr. Weinberger that will tell you how to go ahead with the suggestion therapy. And it is very fulfilling treatment when you see this children's cough, which has been there for months, disappear in your clinic. So the points to remember are functional disorders or respiratory disorders are increasing, no doubt. Whether they will continue to do so once the pandemic finishes, it's difficult to say. They can cause significant distress to the child family as well as the treating doctor. They need to be considered if the symptoms do not match the signs. So they are not a diagnosis of exclusion. In other words, when you see a child with chronic cough, don't think about functional disorder after you do a CT scan, a bronchoscopy, lung biopsy, etc. Think along with the medical cause. You always put this functional as your differential diagnosis, especially if the signs and symptoms don't match. Medical causes should be excluded by detailed history. How a detailed history will help, I will discuss interesting cases in the panel discussion. And judicious use of investigations. Once diagnosed, they should be managed sensitively, and that is where the art of pediatric practice comes into picture. And pediatricians should not seek to hesitate help where needed, whether it's from pediatric pulmonologist or from a mental health professional. With this, I would like to thank, and I hope that I've sensitized people about the functional respiratory disorders. Thank you. I'll stop screen sharing.
Dr. KV, are you available?
Yeah, I think Dr. Jekka, with the presence of Omicron all over the city, I think everybody is coughing now, whole city. I think the cough slides which you have shown almost relate to most of the coughs which we are seeing, but they are mostly pathological coughs which we are seeing. So thanks for the presentation on functional cough disorders, which is quite difficult and challenging for most of the pediatricians in and around. Any questions? I think you people can push it across.
Dr. Jakka, it is a very, very relevant topic, and we are seeing a lot of children with functional disorders like this, breathlessness, cough, and tics, etc. Very, very difficult to manage. That is one thing. It's a big challenge to manage, and it's a bigger challenge to make the parents understand that this is functional. And I think that is the limitation, and that is the reason why these children get into these problems. I think the home environment, I've seen many parents are over the top about COVID. You will see some of these parents who come in, they themselves will be wearing a surgical mask and a cap and gloves even today. So and these are the kids who run into bigger problems. And I've had 2 children, one kid who did not stop coughing for 5 days continuously. Now, this child used to sleep at 2 a.m. in the morning and get up at 5 a.m. in the morning and continuously cough. He had a past history of asthma, so that became easier for him to cough. And many of these children have a past history of asthma or an underlying disorder. And there was a history of little anxiety and depression in the family. So all these things, I think, a family history of psychiatric disorders and how the family milieu is extremely important for these children. And not going to school, no physical activity, all this have precipitated this problem. I do remember Dr. Gary Cornett giving a lecture on, he had in one of the Respicons, he had given the oration. And he did speak about cough in asthmatic children when they're not wheezing. And he said, even that was even before COVID, he says we are seeing a pandemic of children who cough and who are not breathless, and we do not document wheeze and they're just coughing. So he had warned, he says, India is not seeing it now, but you will come there where you will see so many functional coughs that it will be out of hand. So that is going to be an explosion. And I think COVID just kind of pushed us over the balance. So this, but brilliant talk. I thank you for this talk.
Yes, Dr. Indu, I completely agree. I'm seeing one functional respiratory disorder every week since the onset of COVID pandemic. So I'm sure all of you must be the same as well. So yeah, and usually when you see these children, it is the family as well who are hyperactive and not hyper anxious as well. So I saw a family recently who put 4 layers of clothes on the child and 2 jackets on the top. So that sort of anxiety they have. Thank you.
Yeah, thank you, Dr. Srinivas Chekka garu, for wonderful presentation and enlightening us with the wonderful things about breathing, functional breathing disorders. Thank you, sir. Thank you very much, sir.
Thank you, sir.
And next session, we'll go ahead with latent tuberculosis in children by eminent Dr. Suma Shivalan. He did MBBS Pediatric DNB and MNMS and FCCP USA, and is a consultant pediatrician and pulmonologist in the Sundaram Medical Foundation. Thank you, sir, for accepting this invitation, and go ahead, sir.
Thank you, sir. Thank you, Chairperson, and thank you, Twin City Branch, for the invite. And I will go to the topic directly, and it is on latent tuberculosis. Though we keep saying latent tuberculosis, now the agreed term is tuberculosis infection. We will see why it is so. And with regards to latent tuberculosis, this has been always a gray area. We all think we know, but at the same time, we don't know much. And the recommendation also kept changing frequently, and not much emphasis was given in the past. Now, a lot of emphasis again is given for it right now. So we need to have a bit more of clarity to already what we know. So that's what I'm going to highlight upon today. So we need to know regarding RNTCP. We all get confused that what is this RNTCP, what is the present thing, what is the NTB strategy. Actually, RNTCP was based on DOT strategy, which was introduced in 1997. Then in 2016, WHO came with the NTB strategy, meaning to decrease the incidence of TB by 80% and TB death by 90% and 100% decreasing in cost and its effect on the family by 2030. So by 2030, they are planning to achieve this. And based on these lines, India adapted the NSP for TB elimination. That is the National Strategic Plan for TB elimination. And on 1st of January 2020, RNTCP is restrained as NTEP, that is National Tuberculosis Elimination Program. So RNTCP is virtually not there. It has been recoined as NTEP. That's something interesting to note. As a part of NTEP, TPT, that is a tuberculosis preventive therapy, that is the treatment of latent tuberculosis, is an integral and an important part. This is given to people who are infected with TB bacteria and or have been exposed to it, and who are at a higher risk of developing TB disease as compared to the general population in the near future or later. So that is a high-risk target population which we are trying to concentrate upon. So with regards to TPT, is a more critical public health measure to protect both individuals and the community from TB. So previously, not this much of importance has been given. Now it has been given from January 2020. As a continuation of that, you will see what is latent tuberculosis. So previously we kept saying latent tuberculosis. Now it is called TB infection. Why? Because people now say that infection cannot always be considered latent. Infection is an infection. This is going to be a problem, if not now, sometime later. So let us not call them latent. The moment we say latent, we tend to take a back seat. That's why it's been called a TB infection. So infection means infection. So with regards to TBI, it's a persisting immune response to stimulation by the Mycobacterium tuberculosis antigen with no evidence of clinical manifestation of the disease. Mostly, the harbors a live but dormant organism. What I mean by mostly is, if you're treating the first time, it is an infection. Probably they can also persist to have a tubercular skin test or a IGRA being positive. So there, they need not exactly be the infection itself. So that has to be had in mind. But mostly, it is considered to be a live and dormant organism, where the only sign of TB infection is either a positive skin test or IGRA. And they are asymptomatic. Their chest X-ray and the sputums are negative, and they are not infectious, and they are not contagious. That is something important to note. And exception, as I said, to this is meeting all the above criteria. A few asymptomatic and early active TB cases, they need not be symptomatic, and they need not have any signs and symptoms of infection, and their TST and IGRA can be positive. And if we evaluate them, they can have an abnormal chest X-ray or a sputum being positive, and they are also contagious and infectious. So that's why when you think of TB infection, it is our mandatory duty to rule out an active tuberculosis in them. That is possible in early active asymptomatic cases. So why TB preventive therapy? That becomes important because it is offered to individuals who are considered to be at the risk of developing TB infection as compared to others in the general population. And mostly 5 to 10% of infected people tend to get into full-blown tuberculosis within the first 5 years. And this risk is more in patients who have a compromised immunological status, and it is more than 25 times increased risk in patient with a confirmed contact with a confirmed TB patient, bacteriological confirmed TB patient, and it is much higher, around 20 times more with regards to HIV and co-infection cases, and any immunized, immunocompromised individual are also at an increased risk. So with regards to the burden of TB infection in India, approximately 35 to 40 crore Indian population have TB infection or the so-called latent TB, of which 26 lakhs are estimated to become florid tuberculosis or tubercular disease every year. And with regards to the Indian population, as of 2020, it is 138 crores, and the US population is approximately 35 crores. And the number of people of a US population load of Indians have TB infection. That is a rough estimate for us to know. So looking at these figures, are we supposed to be scared? No, definitely not. We need to be cautious and vigilant. And one more, guidelines for programmatic management of tubercular prevention treatment in India was released in July 2021. And it is a 123-page document. So on looking at that again, you need not be worried. I'll be telling you the gist of what it tells you. And there are a few terminologies we need to know. Bacteriologically confirmed TB. When we say that, it is either by smear positive or by culture proven, or by gene expert or the molecular test being positive. So if these three are positive, then they are confirmed as bacteriological confirmed TB. And with regards to the index patient, it's any person who's been new or recurrent TB being diagnosed in a specific household, and he is the first person in that locality who's been confirmed or diagnosed as TB. He becomes the index case. So person surrounding the index case is for contact tracing. So at-risk individual is in whom the prevalence and incidence of TB is significantly higher compared to the general population. And this high TB transmission setting is in healthcare worker, prisoners, mines, slums, tribal and migrant laborers, meaning wherever there is overcrowding and poor socioeconomic background, and poor cross ventilation. These are at risk for high risk transmission. And what is a contact? Always we keep saying about no history of contact with tuberculosis or history of contact with tuberculosis, whereas there was no exact definition to say. And if at all, if it was much of a vague thing. It is left to each one's interpretation. Now they have said that any individual who is exposed to a person with active TB disease is considered to be a contact. And close contact is a person who need not be a household, but shared an enclosed space like a social gathering, workplace, or any other facility for an extended period during the day, with the index case during the past 3 months before commencement of TB treatment. So this is one. So if I am having TB, my colleagues and my postgraduate all are considered to be a close contact. And household contact, meaning they're household people. So we always emphasize on household contact, but not on the other aspect of close contact. So that also has to be emphasized. Here again, the same definition for close contact with regards to the household people. And here it is interesting to note, if you stay in the same house more than one night with a person who has had tuberculosis, active tuberculosis, you are considered to be a significant contact. So contact investigation is targeted both for household contact and other close contact. So what are the target population we are talking about? Here, with regards to person living with HIV positive individual, all adults and children above 1 year and are to be given with Tb preventive therapy after ruling out a disease. So if a person is HIV positive, anybody in contact who is more than 1 year has to be given Tb preventive therapy after ruling out active tuberculosis. So if he has active tuberculosis, then he has to be treated and not given a preventive therapy. And children who are less than 12 months of age, there it becomes an exemption, provided if they are in contact with a TB active case. In less than 1 year, when people living with HIV positive individual, if there is a contact of active tuberculosis, then you treat, otherwise you need not treat. And the other criteria are any children less than 5 years of age who's a household contact of a pulmonary TB has to be treated. So here, interestingly, in all these categories which we spoke about, there you need not bother about your tubercular skin test status. If that is negative or positive, you are going to treat. You have to make sure they don't have an active disease. Here again, children who are above 5 years of age with who are household contact of TB patient, here there is an exemption. Here, if they are sensitized with TB infection, meaning with your skin test or IGRA is positive, then you can treat. If they are not positive, even if they are in contact, household contact of a person, then you have to monitor rather than treat. Less than 5 years, you will treat irrespective of MAN2 or IGRA. More than 5 years, if MAN2 or IGRA is positive, then you treat, otherwise you wait. The same category is for other individuals who are on immunosuppressive therapy, who are on dialysis, who are awaiting organ transplant. Here, if they are MAN2 positive or IGRA positive, you treat after ruling out TB disease. Otherwise, you can wait and monitor for evaluation of symptoms. So other risk group like diabetes mellitus, malnutrition, and smoking and alcohol, they are not, though they are considered to be at increased risk, they are not in line for TB preventive therapy unless they have other risk factor like TB exposure or HIV people living along with, or any household contact with active case. And in a high transmissible setting, like I said, wherever overcrowding or less cross ventilation and low socioeconomic setting, this depends on the general assessment of that particular state to make sure whether they are entitled for that or not. As in general, though they are at higher risk, you need to be cautious in putting them on TB preventive therapy en masse. So here, any target population, as I said, first rule out active tuberculosis. If you rule out active tuberculosis, then you can put them on TB preventive therapy based on the recommendation. Otherwise, if they are positive for a disease, no point in putting on TB preventive therapy because that is not going to take care of that, and that might increase burden in the community and also drug resistance. So any child, first make sure they don't have an active disease, especially in the target population. If they are not having an active disease and if there are no contraindication for TB preventive therapy, then they can be started with TB preventive therapy. So the regimens are only 2. Now, as of now, only 6H is available with the government agency. 3HP, that is INH and rifampicin, is also been recommended as a weekly dose for 3 months. But this has not come into supply. All these are going to be supplied only by the government. In private, we are not getting these combinations freely as what was available before. So now let us know about 6H. In children less than 10 years, 10 milligram per kg in the range of 7 to 15 milligram to a maximum dose of 300 milligram per day is given. Children above 10 years of age, 5 milligram per kg per day can be given. And the maximum dose should never exceed beyond 300. So for all these target population who are not MDR-TB exposed, then 6H, that is 6 months of INH is used as a TB preventive therapy. The alternative to that is 3-month course of HP, that is INH and rifampicin, which is given as a weekly dose. But for now, it is not freely available, so that we have to have it in mind. With regards to MDR-TB contact, then there is no point in giving the 3HP or 6H. Here, we need to know certain things. Globally, 3 in every 1,000 people carry MDR-TB infection, not exactly disease. And the prevalence of MDR-TB doubles in children who are less than 15 years of age. And household contact of patients with MDR-TB are at an increased risk for TB infection than contact with drug-sensitive TB. So a person with MDR-TB, all his household contacts are at an increased risk of TB infection. And so if they fit in the criteria of the target population, we have to treat them with the appropriate drug. However, MDR-TB or drug-sensitive TB, the risk of progression of TB disease does not differ between the 2 groups. That is something reassuring. And concern of high resistance when treated with daily dose of...
The voice is breaking, sir.
4 months of rifampicin is not scientifically supported.
5.
Yeah.
So
Okay.
5 more minutes, sir.
Yes, sir. And here it has been found that by treating these people with an appropriate MDR-TB contacts with appropriate preventive drug, it decreases the incidence of TB in them, more so the MDR-TB in them by 90%, and is also found to be cost effective. Here, instead of 6H and 3HP, here what they recommend is 6 months of levofloxacin, that's for you to know, and 4 months of rifampicin. And the contraindication for TB preventive therapy are any child with active disease. They qualify for treatment and rather than for preventive therapy. And any child with acute or chronic hepatitis, we have to be careful, and it's a contraindication. Why? Because most of these drugs are hepatotoxic drugs. And concurrent use of any other hepatotoxic medication like nevirapine or any other drug, and regular or heavy alcoholic, even in adolescent, we see a bit of alcoholics nowadays. And signs and symptoms of peripheral neuropathy like persistent tingling, numbness, or burning sensations, this is a contraindication. Any known hypersensitivity reaction or significant allergy to these drugs is a contraindication. And follow-up of monitoring, always see for 4S, that is cough, fever, night sweats, and weight loss. And for drug-related side effect, you have to monitor. And signs and symptoms of TB evolving during the course for preventive therapy has to be always looked in terms of. And here, one more important thing to notice, efficacy of TB preventive therapy is greatest if 80% of the dose is given in 133% of the duration of regimen. Yeah, let me explain on what is that. Say, for example, if it is 6H, it is for 6 months duration, that is 180 days. And 80% of these doses, 144 doses. So of the 180 dose, if 144 doses given, then it is considered to be effective in the stipulated time. So 133% of expected duration is, instead of 180 days, if it is 100%, and 133% is 239 days. So here what is expected is at least 144 doses should go within 239 days. though we call it 6H. That is to have an idea of failure and defaulters. So that we have to have it in mind. So if it is missed dose, we can always try to top up. And if it is more than 80% of the dose is not being completed during that stipulated time, then probably we need to consider to restart your TB preventive therapy. So follow-up investigation here, it is important to note that LFT need not be done as a routine unless if there is a pre-existing liver disease or in a chronic alcoholic. And if the child is on, if a person is on, an adolescent is on pre-HP, and if they become pregnant, then we have to change to alternate therapy because the safety of rifampicin has not been established in pregnancy. And always during therapy and after therapy, monitor for development of TB disease. And in children born to mother with TB disease, make sure the mother gets adequate treatment and infection control. And if the newborn is well and if there are any no signs and symptoms of TB infection, put them on 6H along with pyridoxine. And BCG vaccination should not be delayed. And breastfeeding should not be delayed unless if the mother is severely ill or sick. And breastfeeding can be continued and contact with the mother to an extent can be continued, along with all these cough etiquette and masking of the face. And any child whose mother is on ATT should receive pyridoxine in addition to TB preventive therapy. Why pyridoxine with ATT? Because now the dose has been increased from 5 to 10 milligram, and pyridoxine INH interface with the pyridoxine metabolism, and associated malnutrition also increase the risk of side effect. And pyridoxine deficiency is difficult to recognize in children. And pyridoxine is a safe drug, water-soluble vitamin. Overdosing is not possible because it gets excreted in the urine. So here it is interesting to note that pregnancy again is not a contraindication of TB preventive therapy. And there are two questions which is important to know. That does TB after treatment with TB preventive therapy, can it happen again? Yes. Yeah, and if treated for TB infection in the past, usually they do not need treatment again, even if they are positive for MANTO or IGRA. But if they are re-exposed or someone with TB or if they develop a TB disease, this is a different question. And can they happen again? This is a question. Yes. If TB preventive therapy is for prevention of disease at that particular infection and not for prevention for all future infection and disease, so possibility of a future contact and exposure always exists. So these things have to be had in mind. And a child who's once treated, always based on MANTO and IGRA, you need not treat them in future also. Overall, this is one slide which you need to know. TB preventive therapy is advised in all less than 5 years of age. There is a wide distribution. Can you unmute, please? Can you mute, please? This is an interesting slide, an important slide. This alone will give the crux of the whole presentation. TB preventive therapy is advised for all children less than 5 years of age, irrespective of TB skin test in household contact of primary pulmonary tuberculosis patient, and all children less than 5 years of age, if they are skin test positive or IGRA positive, has to be treated. In all children more than 5 years of age, if they are MANTO positive in background of household contact, then they have to be treated. And skin test positive in children of immunosuppressive drug dialysis or awaiting transplant, they have to be treated. Child born to mother with TB infection have to be treated. And all HIV infected children with contact or MANTO positive by 5 millimeter has to be treated. People living with HIV and MANTO positive, irrespective of the status, have to be treated. And children less than 1 year, if they have a contact with active TB, they have to be treated. Otherwise, they can be monitored. And the efficacy of TB preventive therapy is established if 80% of the dose is taken in 133% of the stipulated duration. Thank you.
Thank you, Dr. Soma.
Thank you, Dr. Suma Shivalan. Just a few questions from my side. It was an excellent presentation. You have said that on nearly 20 to 25 crore people in Indian population will be having latent tuberculosis. Yes. That equates to 1 in 4, if I'm not mistaken. And I believe all doctors who are working in busy centers will definitely, especially in congested centers, will definitely have latent tuberculosis in them, if I'm not mistaken, with the ratio which you are seeing. Second my question would be, because of the onset of COVID, we have seen that the data, there is a decrease in incidence of tuberculosis. Actually, it should be the opposite. Because of the onset of COVID, a lot of immunocompromised situations have arisen. The TB should have increased. But the incidence of tuberculosis across the nation has actually decreased, if I'm not mistaken. You can correct me if I'm wrong. And my second question is role of ESR, because latent tuberculosis, you don't do a manto for every child if he's doing well. If there is any point. Role of ESR as a clinical parameter. I know it's a very weak parameter, but any role of it in latent tuberculosis?
No, there is no role for ESR. Definitely no. ESR doesn't tell you whether it is tuberculosis or not. It just tells you the inflammation as a marker. So that is not so. And with regards to latent tuberculosis, there is not much of inflammation. If it is an inflammation happening, it becomes a disease rather than an infection. One. With regards to the TB, that might be your observation might not be wrong. But we see a lot of tuberculosis in our center. In child rest, we see a lot of cases because they tend to postpone. And when it is not possible, they ultimately reach a referral center. So that's the seeing. And we see, in fact, a lot of tuberculosis in the last 2 years than what was before.
Thank you, Doctor. Soma, any other queries?
There is one question in the chat box which says tuberculosis preventive therapy for pulmonary tuberculosis. Any tuberculosis preventive therapy for extrapulmonary tuberculosis? Is it recommended?
No, they all keep talking about acute tuberculosis. Acute tuberculosis here, in sense, anything can be an acute tuberculosis. What they mean is a contagious disease, meaning it's a pulmonary tuberculosis. The contact becomes a pulmonary tuberculosis. But most of the time, you need to remember, even with TB lymph node, though the child is not coughing, if you do a BAL in these children, some are turning out to be gene export positive and culture positive. They were not having cough, not much of changes in the chest X-ray. When you do a CT, small parenchymal changes will be there, predominantly lymph node, mediastinal node, and the other nodes will be there. So that we have to. So if you have ruled out, pulmonary thing is not there. A TB meningitis by itself is not a contagious thing. But we have to remember, the way that child got exposed, even others might have been exposed. So that is a difficult, tricky question. But we have to apply our clinical, judicious clinical approach in these scenarios.
Dr. Somo, can I ask a question? Outside the home contact, I mean, what is the duration of contact needed to say that someone has been exposed to that? Because sometimes parents ask that question to us.
See, even for COVID, they say 15 minutes of significant contact, less than 3 meters. And these things cannot be quantified. But anybody who's known to be on, according to me, anybody who's on ATT for all practical purpose, considered to be a significant contact. If you spend enough and more time with them, to the extent you can recollect, you yourself become a significant contact. It's not that if you try to quantify asking them significant, then the question arises, what is significant? So that becomes, if you are being exposed to him and if you know him well and well, and if you are able to recollect this association, then probably you become a significant contact. That's what I say. And even the previous recommendation, now they say 3 months before the start of antibiotic. Previously, it was anybody getting exposed who has been exposed in the last 2 years. He himself becomes a contact. So anything you can recollect in a reasonable period of time who's been on ATT and significant association with them, then it becomes a contact.
And if you recommend the preventive therapy and the parents refuse, practically how do you follow them? Like how frequently you follow and what do you do for them?
Now everything is being followed by this RNTCP cell, meaning everything is drugs. Even in our private practice, we give it through that RNTCP cell. Though it is not an RNTCP cell, still we keep calling them RNTCP cell. They maintain a good follow-up on them. They call up, and if they are not on follow-up, they inform us.
Okay, thank you. Thank you, sir.
Thank you, sir. Thank you, Dr. Somu, for a wonderful presentation. Next session, I would like to introduce Dr. Indu Koshla. She's an pediatric pulmonologist, and she's an European diplomat in pediatric respiratory medicine attached to Leelavati Hospital Research Center and NHSRCC Hospital for Children, and director of Dr. Indu Newborn and Child Care Center. She has a special interest in flexible bronchoscopy, sleep medicine, mucociliary disorders, and she's a core faculty for ATM, RTA, and 5V's module for IAP. She is a national convener of NAPS module on sleep, and she's an international advisor to the Congress of International Pediatric Pulmonology, and she has given multiple lectures at national and international conferences and established a level 1 sleep lab for sleep disorders. Good morning, ma'am.
Good morning. Thank you for the kind words, and I would like to thank the Twin City branch for giving me this opportunity. Hyderabad to me is a city of pearls. When I come there, I always buy pearls, and thanks. And as a woman, I really enjoy it. So today I'm going to give you an overview of sleep disorders in children. And I need to tell you that it's a vast topic, and it's impossible for me to cover it in 20 minutes. So I will just run past and give you an overview on how to approach children with sleep disorders. Okay. Before we talk about unhealthy sleep or sleep disorder, we all should know what is healthy sleep. So, and I'm sure all of us here would kind of try to analyze themselves by looking at this slide, whether they have a healthy sleep or not. So healthy sleep is, if you hit into the bed, you should sleep very quickly. Within 15 to 20 minutes, you should be asleep. So your sleep latency should be less than 15 minutes. You should stay asleep through the night. No troublesome night awakenings. Of course, barring the few emergency pediatric calls that we all keep getting, we should be able to sleep through the night. We should rise in the morning feeling fresh and not troubled, not being yanked out of bed because the alarm clock rang, but we should be able to get up, and we should not feel sleepy during the day. Many pediatricians would sleep in a car ride if they're going from one center to the other but that's because they're always sleep deprived. So no excessive daytime somnolence. So this is what we call as healthy sleep. But why do we really need to sleep? We spend 1/3 of our life sleeping, and still, honestly, medical science does not understand the true reason why we need to sleep. And there are many theories. One of the theories is just restoring. We know the REM sleep restores mind, the non-REM sleep or the slow wave sleep restores the body. There's also a growth theory. We know that growth hormone is secreted in deep sleep, that is non-REM sleep, and it's important for children that they sleep well so that they can grow. There are many other theories like the evolutionary and the adaptive theory, which says that sleep is following a phylogenetic process, and we sleep differently from our ancestors. And in some species, it is important for survival, especially the REM sleep. Many animals go into hibernation and they sleep. Probably they conserve energy, conserve metabolic rates. Probably it also helps us to learn new things, consolidate memory, and of course there's a theory that it detoxifies us. So these are all theories. Honestly, we still don't know why we spend 1/3 of our life doing this. All right, but we definitely know that if we don't sleep, there are effects, and these effects could be acute effects or it could be long-term effects. The acute effects could be mood, and if we have had a bad night, like I had last night. I had a child on a sleep lab who was undergoing titration and gave a lot of trouble to the sleep technician, so the technician gave me trouble. So morning you might get up anxious, irritable, and that's when Dr. Suman called me in the morning, log in for the trial run. I was just still getting yanked out of bed. So you may be anxious, you may be irritable, you'll have increased temper tantrums, short-temperedness, depression. This can come acutely, or mood changes. A little long-term sleep deprivation. Typically, you see this in adolescents who are chronically sleep deprived. They sleep late, get up early, poor concentration, memory, difficulty in learning new tasks, or maybe a drop in school performance. But long-term, and we are seeing a lot of this in COVID because there are so many children who become obese. So you may have high blood pressure, obesity, diabetes, immunosuppression. Immunity is boosted in sleep. So children who don't sleep well have immunosuppression, and also there is a risk of injuries, especially people who are driving, who may be doing some task, but because they are not fully active because they have not slept well, there is a risk of injuries. So the international classification.
Indu, your voice is breaking.
My voice is breaking. Is it better now? Is it better?
Yes, ma'am. Yes.
So the International Classification of Sleep Disorders has classified more than 80 sleep disorders, and they are classified as one. The first classification is insomnia disorders. And you will say, do children have insomnia? Yes, children do have insomnia. What we call in children, younger children, is something called as behavioral insomnia of childhood. And this is because either the parents have not set limits that this is the time you should get to go to sleep and go to bed and get up, or you can have sleep onset association and insomnias. That is when the children need to be rocked or breastfed or taken out for a car drive in the middle of the night for going back to sleep. So these are the two kinds of behavioral insomnias of childhood. You may have mixed, where you may have a limit setting and a sleep onset association insomnia. Then you have circadian rhythm disorders, which are typically seen in adolescents. They sleep late, get up late. In the old age, you sleep early and you get up early. So you may have either a delayed sleep phase or an advanced sleep phase kind of circadian rhythm disorders. Then the major chunk is sleep-related breathing disorders, which we all are aware of, which is obstructive sleep apneas, hypopneas, and central hypoventilation syndromes, which commonest reason being tonsil adenoidal hypertrophy, but you have a whole lot of reasons why you could have a sleep disordered breathing. Then you have central disorders of hypersomnolescence. Typically, we don't see too much of this in younger children, but you can, and these are children who sleep excessively. And in this category, to name a few, is narcolepsy type 1 or 2 or idiopathic hypersomnolescence. Then very commonly what we see in children are parasomnias. These are disorders where children will get up with a confusional arousal, or they may sleep talk, or they may sleepwalk, or as a REM parasomnia. So these three which I've mentioned now are non-REM parasomnias seen in the first half of the night. Then you may have a REM parasomnia, which is nightmares, which come in the REM cycle, which is later part of the night. And these are parasomnias where children remember, they think they've seen a ghost or they've seen a monster, and the next day morning they will get up, they will remember everything. Non-REM parasomnias, first part of sleep, the non-REM sleep, the deep sleep, and children have no memory of that. So they'll get up, they will be shouting, screaming. The parents might try to console them, but they will not get consoled. So these are non-REM parasomnias. So these are very, very common disorders. But typically as pediatricians, we probably do not take adequate history and we may miss all this. Then you have sleep-related movement disorders. For the want of time, I will not show you the videos, but I have brilliant videos on this. Here you have something called as restless leg syndrome. Here the child in the latter part of the evening will say, my leg is hurting, press my leg, massage my leg. Or the child will say, I've got some funny movements in my leg. So this is restless leg syndrome. Whereas periodic leg movement disorder typically occurs when the child has gone to sleep, shakes his leg so much that it disturbs his sleep. It disturbs the parent's sleep also. So these typically occur because of the problem in the dopaminergic pathway, and this occurs because of iron deficiency. Doing ferritin levels, giving them iron would help solve many of these children's problems. Then we have a lot of other disorders of any chronic illness, any chronic medical illness, rheumatological illnesses, pain disorders, neurological disorders, which may also affect sleep. So the list is big, right? And obviously I cannot cover it in 20 minutes, but I thought I'll just give you an overview. And today I'm going to talk about how common are sleep problems in children, what are the usual manifestations, how do we assess a child clinically, how do we screen them in our busy practice. My aim is to sensitize all of you today. What are the diagnostic modalities, what is a sleep study, and when do you need to do it? Okay, so what is a sleep problem? So sleep problem, every person will have a different perception and tolerance to a sleep problem. There may be families where children sleep at 2 and get up at 11 in the morning, and they're also happily doing it and they're well adjusted and they will not call it a sleep problem. To others, it may be a problem, right? And to some, it's okay if the child gets up in the middle of the night, breastfeeds and goes back to sleep, or it's okay. So that is the way of the family tolerates it. But sleep problem is a pattern that is unsatisfactory or a cause of concern to the parent, child, or the physician. Okay, and generally, I've seen most of the time the sleep problem is noticed by the parents when it disturbs their sleep. That is the time when most of the time parents bring the child to us. And typically working moms, they say, oh my God, my child didn't sleep the whole night. I have to go to work tomorrow. And that's how they come to you. Prevalence is high. It's about 20 to 40%. It is a fact that there is a very high prevalence of sleep disorders. So why sleep screen? Because they are reported, sleep problems are reported by a quarter. So 25 to 30% of parents will report a sleep problem in children, especially below the age of 5 years. It could be simply like a confusion, arousal, a terror, a nightmare. And there is a significant clinical impact, because if these kids don't sleep well, parents don't sleep well, there could be a lot of problems. So there could be a poor behavior, school performance, obesity, and all the negative effects that I mentioned. Also, do remember that if mothers who chronically don't sleep are very depressed mothers, so it totally affects the family dynamics. As pediatricians, we are not trained to adequately address and diagnose sleep issues, and therefore we underdiagnose them. And the natural history can be changed by screening and intervention, and there are available effective treatments, and therefore we should know about sleep problems. And there are a lot of data even from India, but of course there is still less data of the kind of problems which have been seen in children, both in school going children, adolescent children. So typically a good 42% was reported in this paper, and there are many such articles to the effect to show that there are sleep problems in children all over the world, including India. So the most important, as I told you, was sleep disordered breathing, and it's an umbrella term which covers chronic conditions in which there is partial or complete cessation of breathing, which occurs many times throughout the night. This leads to sleep fragmentation. It impacts gas exchange. So that is where our worry is. If it impacts gas exchange, the child can be hypoxic, the child can be hypercarbic through the night, and which can impact his neurological outcomes. It also leads to daytime symptoms. Okay, and this, in the sleep disordered breathing spectrum, we have obstructive sleep apneas, we have central sleep disordered breathing, and we have hypoventilation syndrome. We also have upper airway resistance syndrome, which I'm not talking about. So how do they present to us? So typically there is a history of snoring, but let me tell you that 15% of children will normally snore, right? And they are normal snorers. And absence of snoring does not rule out obstructive sleep apnea, and presence of snoring does not prove obstructive sleep apnea. So this is just a lead point to tell you that this child could probably have a sleep disordered breathing. But if you have a child who's having frequent snoring more than 3 nights a week, and has labored breathing, he gasps, snorts, or makes noises, or anybody has actually observed an apnea. The problem is most of these apneas occur in the REM cycle, in the REM phase, which occurs in the latter part of the night. Many a times children are sleeping in another room. Many a times parents themselves are asleep at 2, 3, 4 a.m. in the night, and all this goes unnoticed. Or if you have a child who develops a secondary nocturnal enuresis, meaning this was a child who was very well controlled, and then suddenly now he started bedwetting. So you, after ruling out all other causes, one of the reasons you need to think of is obstructive sleep apnea. You may have a child who may sleep in odd postures. He likes to hyperextend his neck to keep his neck airways patent. So this is a kid who probably has obstructive sleep apnea. I had a parent who had a child with Down syndrome. This kid was 30 years old. The father comes and tells me, for last 30 years of my life almost, this child is sleeping in a posture in such a way that he sleeps on my tummy with his head extended. That's because children with Down syndrome have a very, very high risk of obstructive sleep apnea. So if you have a child who's sleeping in odd postures, please think of obstructive sleep apnea. Cyanosis, headaches on awakening because of incomplete sleep, daytime sleepiness. But mind you, children who may not sleep in the night may not have daytime sleepiness because they may hypoventilate through the night, have hypopneas, they may sleep through it, and they may be hyperactive the next day. So hyperactive children, also a history of sleep disordered breathing is to be asked for. And of course, learning problems. When you examine them, they could be either be underweight because they've spent so much of their energy trying to sleep, or you may have on the other end obese children who have obstructive sleep apnea. You may have tonsillar hypertrophy, you may have adenoidal faces. Now I've highlighted this, but the size of the tonsils, the size of the adenoids does not correlate directly with obstructive sleep apnea. So you may have large tonsils and obstructive sleep apnea, but that does not mean that small tonsils cannot cause obstructive sleep apnea. That's because it's not only the size, but it is also the tone of the upper airway and many other factors which lead to obstructive sleep apnea or sleep disordered breathing. Then you may have kids with craniofacial abnormalities in the form of Sapir-Robbins syndrome, micrognathia, retrognathia. These children may have high arched palate. When you have a high arched palate, we know we look at it in a syndromic child, but a high arched palate tells me this child is mouth breathing. When you start mouth breathing very early, the gush of air into the mouth remodels the arch of the palate and causes it to be high arched. So a high arched palate is in a given child is suggestive of mouth breathing, which is again a very important finding on clinical examination. Failure to thrive and systemic hypertension are all markers of OSA. How do you approach a child of sleep disorders? Now here I will talk to you about how you take a sleep history. In your busy practice, I hope after today's talk, I could sensitize you enough to spend at least a minute more in your clinical practice to talk about, to take history about sleep disorders. For me, at the age of 6 months, when the child comes for his flu shot or the weaning food advice, I include in my counseling sleep hygiene. And maybe that's the separate lecture by itself, how you must sleep train the child. Today, educated Google parents, and I know Hyderabad is an IT hub. So many of the parents must be reading about sleep training and asking you questions. So you must include that in your counseling when you see a child at 6 months. So there are some sleep questionnaires. I'll talk to you about them. Sleep diaries, actigraphy, smart watches, which tell you about REM sleep. I told my son, like, okay, you must sleep on time and get up. He says, hello, don't worry about what time when I have to get up. My watch tells me when I'm in the proper stage of sleep to get up. Are they reliable? I'll talk to you about it. Home videotaping, oximetry, sleep studies, and the multiple sleep latency test. So this is the main questionnaire that I want you to focus on. It's called BEARS. Easy to remember. BEAR stands for B, bedtime problems. So you see, I have made it into 3 different age group charts. One is the toddler or a preschool, then is a school age and a teenager. The reason is, for a teenager, you need to ask the child himself or herself. And for a younger child, the parent needs to be asked the questions. So does your child have any trouble going to bed? Or is there any sleep association? He needs this, he needs to be breastfed to go to bed, or he needs to be rocked to go to bed, a younger child. Or does he have any problem falling asleep at any bedtime? Even you ask an adolescent, do they sit down with their gadgets at night and they don't fall asleep? And do they complain that we don't fall asleep for a very long time? The next question is excessive daytime sleepiness. So is the child overtired, takes multiple naps for a smaller child, or an older child goes to sleep when he's driving also feels sleepy? Okay. Awakening during nights. Does your child awaken during the night? Does he have sleepwalking or nightmares? This is for a younger child because these parasomnias are more seen in younger children. Or for an older kid, does he wake up a lot in the night and finds it difficult to go back to sleep? Okay, regularity and duration of sleep. This is what I mean by sleep hygiene. And we need to inculcate in younger children a sleep hygiene. A good practice is a regular bedtime. The child goes to bed at a regular time, gets up at a regular time, has a pre-bedtime routine, and therefore the child's body is trained to have a regular bedtime. So ask for regularity and duration of sleep. In adolescents, please ask how it is different on weekdays and weekends. Okay, sleep disordered breathing, any apnea noticed, snorts, gasps, or snoring. This is what you'll ask. Beyond this, you will ask for any medication that the child may be on, especially in older children, any SSRIs that the child is on that can alter the sleep rhythm, and any movement disorders in the form of restless leg syndrome or in the night sleep periodic leg movement disorders. So there are a lot of sleep questionnaires. Unfortunately, not many of them are validated for Indian settings. But one of the best questionnaires is called the Pre-Pediatric Sleep Questionnaire. This questionnaire is applied to children who are well children between 2 to 18 years. And if you identify sleep disordered breathing on this questionnaire, you need to confirm it by doing a polysomnography whether the child has a sleep disordered breathing. The sensitivity was anywhere from 0.85 and specificity was to 0.87. It is a screening tool and cannot conclude sleep disordered breathing. And it is not very good for children who have complex OSA. So a simple OSA, tonsilloadenoidal hypertrophy, obesity, yes, this may work. But if you have craniofacial abnormalities, neuromuscular disorders, myopathies, etc., syndromic children like Prader-Willi, etc., this kind of questionnaire will probably not give you a good yield. And there are other questionnaires which are not validated for Indian settings, but they show a moderate sensitivity and specificity to diagnose OSA. Now, this was a meta-analysis, systemic review and a meta-analysis which looked at whether clinical history would let us know that by just taking a history of snoring or noisy breathing, would we be able to diagnose obstructive sleep apnea. But what it showed that even if you took a set of symptoms like snoring, obstructive apnea, etc., the sensitivity and specificity to diagnose OSA was poor, right? So again, here the similar study which showed that sensitivity and specificity to diagnose OSA was poor. So signs and symptoms alone, or a single sign or symptom or in combination, do not reliably predict OSA and cannot grade severity. And therefore, we need to rely on investigations to come to a conclusion. So this is another very important way of understanding disorders in children. Sleep disorders is a sleep diary. So you ask the parent to make the child and the parent together probably to make a 2-week record of the child's daily sleep routine. So what time he gets into bed, what time does he get up. So this definitely works for children with circadian rhythm disorders. It works with children who have insomnia, okay, but it is definitely not for children who have obstructive sleep apnea. So it's a simple, but it helps you to know the sleep hygiene of the child. It's a simple, inexpensive screening tool, very easy to implement, and it helps you to understand the sleeping pattern of the child. The limitations are the child might lie, he might write anything else, he may sleep at some time and may write something else. And sometimes the total sleep times are significantly greater than those actually, if you do an actigraphy recording, you might find there could be a disparity. So this kind of a 2-week PDI, and it has helped me a lot in my practice. You can download it from Google. These forms are available everywhere. Give it to the child and let them mark it. So here are the days of the week and here are the timings, right? So the child marks when he goes to bed, you mark it with an arrow down, and the gray shaded areas are when he was asleep. The arrow up is when he got up, okay? You can add into it caffeine, you can add it into it exercise. So if you properly mark, actually I should have shown you another slide where a patient had marked for me nicely. It tells me each day what time the child goes into bed, what time does he get up in the middle of the night, does he nap in the day, if he gets up in the night, how long is he awake. So at a glance, it gives me an idea of his sleep history. So typically if you see in adolescents, on weekdays, they might sleep at X time and get up late, but on weekends, they will sleep later and get up even later. So you can at one glance, see how the child is sleeping. And therefore, this will help you a lot in diagnosing, especially circadian rhythm disorders. So these are these bands which many of the youngsters wear, which you have these smart watches and smart bands, but those are not validated. You have another tool called as an actigraphy, which is worn on the wrist. So how does it work? It has got an accelerometer or sensor. So it records the movements and it records light exposure. So there could be smart kids who might just say, I'll wear it and not move my hand at all. They may manage to put some weight on their hand and not move it at all. And this might show that the child is sleeping. So what it does is if the hand moves, they mark it as awake. And if there is light exposure, also it senses awake stage. So it helps us to know sleep onset, sleep duration, wake time by a specialized algorithm on the computer software program. And it just gives you an information on the sleep habits. So it can evaluate hypersomnia, insomnia, or circadian rhythm disorders and does not help in obstructive sleep apnea. What about pulse oximetry? Can you put a pulse oximeter to the night and diagnose sleep disordered breathing? But the answer is probably no. So the kind of pulse oximeters that we use in the sleep lab are ones which have a very rapid averaging time. What do you mean by averaging time? And the averaging time is just 2 to 3 seconds. So when the drop in oxygen occurs, and when will the pulse oximeter pick it up? So that is called the averaging time. So when we use pulse oximeters for sleep disordered breathing, the averaging time should be just as low as 2 to 3 seconds. If you have normal pulse oximeters that we use, has an averaging time of 8 to 15 seconds. So you have missed the episode which has caused drop in saturation. Therefore, you should use a pulse oximeter which is specified for picking up sleep apnea, hypoxia due to sleep apnea. Okay. And the benefits of pulse oximetry is easy to perform. It could be cost effective and it could screen children, but it is only very good for children who have non-complex, moderate to severe OSA. And if you document a hypoxia, the positive predictive value is 97%. But absence of hypoxia, as I said, most of these normal pulse oximeters have a high averaging time. Absence of hypoxia does not rule out an OSA. So it has limitations as in sensitivity of 43%, negative oximetry cannot rule out, and you cannot use it for OSA, which is complex or with comorbidities. So the gold standard tool is a sleep study, which measures different physiological parameters continuously throughout the sleep period to characterize sleep and to identify sleep disorders. We have different kinds of sleep studies. We have diagnostic studies or we have titration studies. We do titration studies when you have diagnosed a problem. And yes, like last night I was talking, we were doing a titration study on a child. This is a 10-year-old child weighing 80 kg, whom we had done a sleep study 3-4 days back. Sorry.
It's breaking, ma'am.
Is it better now? Better now?
In between, it is going off.
Oh.
Now it is okay, ma'am.
Okay. So a titration study will let me know what are the pressures of CPAP or BiPAP I need to use on the patient. So these are the two kinds of studies. So and these diagnostic studies could be simply overnight oximetry, oxycapnography, which looks at O2 and CO2. You can have a polygraphy study, which looks at the oxygenation and just the flow. How much is the flow going through the nose? Or you could have a complete polysomnography. All of them have their limitations and benefits. So just to give you a brief idea, so here on the yellow is a study which is a complete polysomnography. So what is the difference between this and a cardiorespiratory study is here we also stage sleep. Okay, for staging sleep you need EEG leads. So we put central, frontal, occipital and the mastoid leads. We put EOG leads because the movements of the eyes will tell me REM sleep or non-REM sleep. Then we put a chin EMG lead, which will also help me stage sleep. So this EEG, EOG and chin EMG leads differentiates a full polysomnography from a cardiorespiratory study. Okay. Then in both of them, you have nasal oxygen and EtCO2. So we put two cannulas here to look at the EtCO2 and oxygenation. We put cannulas which measure the airflow. So they are also of two kinds. We have a thermistor and we have a pressure flow cannula, which will pick up, one will pick up apneas, the other will pick up hypopneas. We also have a microphone on the neck area to record snore. So this is your pulse oximeter which is recording saturation. We have ECG leads to look at change in heart rate. Then we have these two bands. Okay. One is a thoracic band and another is an abdominal band. So if a child has an obstructive sleep apnea, he will have paradoxical movements of the chest and the abdomen. But if it's a central apnea, there will be no movements. So these bands pick up the movement of the thorax and the abdomen. Then you have a leg EMG to pick up restless leg, periodic leg movements. Then you have a video camera which records the child. So it helps us when we are generating a report to corroborate with what we saw on the video camera. So the difference between a whole polysomnography and a cardiorespiratory study is absence of staging of sleep, right? So we have no EEG leads, no EMG leads, and no EOG leads here. When we do a level 1 polysomnography, which is typically what I do, it is done in a hospital setting where a technician is supervising it through the night. So that is a level 1 complete polysomnography. I hope I've made it clear what is the difference between the two. So I'm going to skip this slide for the want of time. Okay, so these are all your sensors in the nutshell. You have pulse oximeter, you have a thermistor for apneas, then you have a pressure transducer is for hypopneas, you have two belts, that is abdominal and thoracic, you have a snoring microphone, you have leg sensors for leg movements, then you have body position. When the child changes position, the device tells you the child was in supine position, prone position. That helps us to tell you in which position the child has more apneas or hypopneas. Then you have the EEG head box, which will tell you about all the sleep stages, and you have a synchronous video. So in nutshell, these are the different monitors that you put on a child on a polysomnography. And what do you stage? You will stage in cardiorespiratory studying, you just put wake sleep, active sleep, quiet sleep, and because there are no additional sensors for sleep staging. But in a polysomnography, you will actually stage which stage of sleep the child is along with the other parameters. And what you typically in a polysomnography, you will stage W when you have alpha waves, stage N1 when you have vertex short waves. So these are your vertex waves. Then your stage N2, you have K complexes. These are your K complexes. And delta waves are marker of, that is slow wave sleep, is a marker of stage N3. And in REM sleep, we have these rapid eye movements with the flat EMG. You see EMG is big here all along, but in the stage REM, the EMG becomes flat. So this will help you stage the sleep, right? And this is how we mark apneas. So if this is the airflow sensor in the nose, if it reduces, if the flow reduces by almost 90%, this is an apnea. But if it reduces by 70%, it's a hypopnea. When you have an hypopnea, you should also have a dip in the oxygen level by more than 3%. And depending on the respiratory effort, you can either call it obstructive or central. So if there is no respiratory effort, it is central. But if there is a paradoxical respiratory effort, it's obstructive. You can have a mixed also apnea, where it could be, which could be central, then followed by an obstructive. Okay. Along with the drop in saturation and drop in flow across the nasal sensor, many of these children have a arousal. So especially in hypopneas, you may have an arousal. And when you see an arousal, you see a change in the EEG pattern. You may have no arousal in a hypopnea. You may have an arousal in the apnea, or both ways can happen. Okay. And in a sleep report, you will report the total sleep time. When did the patient start to sleep? When did the patient end sleep? How many apneas occur and hypopneas occurred per hour? How many obstructive apneas occurred? How many mixed apneas occurred? How many central apneas occurred? RERA is respiratory effort associated arousal. Okay, so here the patient may have an arousal, but the saturation of the oxygen may not have dipped. So this is a respiratory event which is having an arousal but does not classify as either apnea or hypopnea. We measure the oxygen desaturation, what percentage of time through the night the child had a low oxygen, how many number of times, how much time it reduced below 3%. And we look at hypoventilation by also looking at the EtCO2, whether the EtCO2 went above 45%. And if it was more than 50%, more than 25% of the night, it indicates a hypercapnia. So this is a typical epoch we get to see. Up on top, you can know which stage of sleep it is. These are your EEG leads. This is your EMG leads. And this is your snore. These are your pressure flows. And whenever it's a wake stage, you're not really going to mark it much because the child is actually awake. And this is the flow thermistor. The pressure flow will tell you hypopneas. This will tell you apneas. This will tell you the chest and the abdominal movements. This is your saturation, pulse, plethysmograph of the pulse, etc., and the position of the patient. So this is how an epoch looks. This is an epoch of 30 seconds, and we mark these sleep staging in a 30-second epoch. When we want to mark a respiratory event, we use a 90-second epoch. This is a 3-minute stretch of sleep for the child. And here, if you will see that the child's flow has diminished, the oxygen saturation has dropped, this will tell me that this patient had a hypopnea or an apnea. And also I will know at which stage of sleep this occurred. All right. So if you have ideally children should have no apneas or hypopneas through the night, and the normal is less than 1 per hour. If you have 1 to 5 apneas and hypopneas, that is number of apneas plus hypopneas upon the total sleep time divided by 60 will tell you the apnea hypopnea index. If it is 1 to 5 per hour, it's mild. 6 to 10 per hour is moderate. More than 10 is severe sleep studies. What about home studies? Many adults do home sleep studies. It's a comfortable home environment. We see the first night effect in children who come to an environment to sleep in a sleep lab. There's a lot of problems. They may not just sleep, and we may get a false sleep report. So why don't we do it at home? It will reduce the effort. It will reduce on the sleep labs. It will also probably cost less for the patient. But it is not validated for children. And I've seen in the sleep lab, children keep pulling out all the monitors. So we do a monitored sleep study because we need to really keep putting it back. And especially in complex OSA, doing a home study is absolutely futile. So therefore, the quality of data at this point of time, this might change later on with time with better improvement in gadgets. But at this point of time, home sleep study is not validated for children. All right. So what are your indications? When will you ask for a sleep study? You can do it when you respiratory indications are when you suspect a sleep apnea, either because of a tonsil adenoidal hypertrophy or when you have removed the tonsil adenoidal. Also, sometimes OSA can persist, and therefore you ideally should do a sleep study in every child with tonsil adenoids before removal of the tonsils and adenoids. Then in complicated OSA, in obesity with craniofacial syndromes, Down syndrome. Down syndrome, it's a recommendation that after the age of 4 years, one sleep study has to be done, and these children should be monitored because as they grow as adults, in childhood also 50% of them have an OSA, and as adults almost 80 to 100% of children with Down syndrome will have an OSA, and all children with neuromuscular disorders. So by the time their muscle strength is weakening, if you do a sleep study, you can document hypercapnia, you can put them on home BiPAP, and you can reduce their risk of getting recurrent respiratory infections, and you can delay their downfall. There are also non-respiratory indications for sleep studies. Sometimes you have nocturnal seizures which look like parasomnia. So to differentiate between the two, you need to do it. We have periodic leg movement disorder, which is only picked up on a sleep study, or suspected restless leg syndrome, narcolepsy. So we do a polysomnography. Following that, the next day we call something called as a multiple sleep latency test to see if this person goes on sleeping. He ideally should not be sleeping after a full night's sleep, but if he goes on sleeping and the REMs come in early, yeah, my last slide. Insomnias and circadian rhythm disorders, only if they have an underlying sleep disordered breathing or a restless leg syndrome, you would do a sleep study. So my take home message is that sleep history is essential. It can help in pick up your pediatric respiratory disorders. Snoring is a lead point, but cannot confirm diagnosis. Size of tonsil adenoids do not tell me that this child is going to get an OSA or not. And sleep disordered breathing may go unnoticed by caregivers as it occurs during REM sleep, very late in the night. The child may be sleeping in the next room and you may not have any idea. So polysomnography is a gold standard. Many a time we just land up doing a cardiorespiratory study, which will also help us get an answer. And in the absence of facilities of a PSG, you can rely on overnight pulse oximetry. You can ask parents to get you simple video recordings, and that will give you a clue. And this may give you valuable inputs then to consider which patient you need to investigate further. Thank you so much.
Thank you, ma'am. Thank you for this wonderful presentation, ma'am. Very elaborate details you have given for us, which we neglect actually in our clinics. Now we are aware that we have to concentrate on sleep disorders also. Thank you, ma'am.
Indu, just one question. There are a lot of barrage of questions for me. This is a very new topic for most of us. First thing is, as long as the child is not kept active, his sleep pattern obviously would be disturbed. And thanks to the sedentary lifestyles we have got, child hardly moves. So forget about actigraphy and smartwatches. I don't think his sleep would be accurate if he's not remaining active. Second would be, as far as the screen time, what is your experience as far as the screen time and the sleep patterns? Does it really, how much does it disturb the sleep patterns and the screen time is concerned? Because relativity is not shown in your presentation. Is there any relativity to it?
Yeah. So let me take your second question first. The screens emit something called as a blue light. Okay. So how do we sleep? When there is something called as a circadian rhythm, right? So we get up when it is light and we sleep when it is dark. So in the night, when we are continuously exposed to screens, so these screens hit the blue light hits the retina, and from the retina it goes to the retino-hypothalamic tract, which inhibits, normally the pineal gland secretes melatonin. But if this light keeps coming, the melatonin does not get secreted. And when melatonin does not get secreted, it delays your sleep onset. So screens will delay sleep onset. So when we have adolescents who are not sleeping in the night, the first thing we tell them is to remove all gadgets and to remove all screens for at least half an hour, 45 minutes before they get into bed. So screen time definitely hampers sleep. The other thing you talked about, sedentary lifestyle and sleep. So if a child is sleeping through the day because of his sedentary lifestyle, his night sleep is obviously going to get altered because he has slept a lot. He will not get sleep, and he will not, when he gets into the bed, he will feel insomnia. So physical activity, especially in the evening time, is a very, very important aspect for one person to get healthy sleep. Now, naps in children should actually stop by the age of 3 to 5 years, right? After the age of 5 years, there should be no daytime naps. Then also the child can sleep better. If a person does take nap, it should be before 4 p.m. in the afternoon, and therefore then they can, and for a nap before 4 p.m., good physical activity in the evening, then this child will be able to sleep better. The other problem which has occurred with COVID is obesity when they have no activity, and that is further worsening their sleep disorder. So these are, and of course increasing screen time. So all these three factors together have caused problem in children who are having a sedentary lifestyle.
Thank you, Dr. Indu. Dr. Arif has 3 questions. Dr. Arif, you can ask those 3 questions, please.
Dr. Arif?
Hello. Yes. Hi,
Yeah.
Indu.
Yeah, hi.
Yeah, I have 3 questions because I think I missed a little bit of yours in the middle. So, did you mention about teeth grinding and daytime hyperactiveness?
Yes.
Hyperactive child. Did you mention about it?
Yes, I did mention about it. I didn't touch about bruxism because in 20 minutes I cannot cover the whole sleep disorders. So hyperactivity is a marker of sleep insufficiency or sleep disordered breathing. In children, in adults, they are hypersomnolent in the day because they have apneas, they get arousals, and therefore they sleep more in the day. But children can have hypopneas and they sleep through the night through the hypopnea, and therefore they can be they may not have hypersomnolescence in the day, but they will be hyperactive. They have ADHD, which is known to be described in children with sleep disordered breathing.
Yeah, and the other about teeth grinding, very important.
So bruxism has been noticed as a kind of a it is described as a movement disorder in children, like teeth grinding, but generally it does not hamper sleep. Generally, it does not cause obstructive sleep apnea or sleep disordered breathing. So maximally it can cause problems it can cause injury to the temporomandibular joint if it is very severe. It can cause erosion of the enamel of the teeth, but it does not really affect sleep. It will affect somebody else's sleep because the child continuously has bruxism and he's sleeping next to you. The parents will be more disturbed. And here the treatment is reference to a dentist for putting kind of blockers between the two sets of teeth to avoid damage to the teeth.
Well, there is another explanation for this teeth grinding, that because of the adenoid hypertrophy and blocked nose and all, because of the compromised airway in the deep stage of the sleep, when the muscles are relaxed, so the airway becomes further obstructed. So the child has to come from the deeper state of sleep to the light stage of sleep, and for that he has to teeth grind and open his airway. Would you agree with that?
So these are all hypotheses, but nothing is proven.
Okay. The other thing is you mentioned about polysomnography for adenoid hypertrophy. Okay. So should polysomnography be the criteria for deciding which patients of adenoid hypertrophy should be operated? I mean, the grading of the polysomnography as the American Society of Otolaryngology recommends.
Okay. So there is a real world situation and there is something called as a real world situation. So there is always a gap there. And I'm sure after me, there's a lecture on the ENT perspective and he will also throw light on this. But let me tell you one thing, that the size of the tonsils and adenoids, you will remove tonsil and adenoids for 2 reasons. You will remove it if there is an infection. So there it is clear cut, you're removing it for recurrent infections. And there are clear criteria and guidelines for that. The second is, of course, when you're looking at obstructive sleep apnea. Now, the size of the tonsils and adenoids really do not correlate exactly with who will get severe OSA or not. Because it's just not the size, it is also the tone of the upper airway which causes obstructive sleep apnea. So if you do a sleep study prior to removal of tonsil and adenoids, okay, then you will be able to document whether the OSA has disappeared or not after that. Because not all children who remove the tonsil and adenoid, especially if you're removing it for an obstructive sleep apnea, will have disappearance of OSA after removals of tonsils and adenoids. So this is a caveat here. So you may not treat an OSA fully by removing tonsils and adenoids because you cannot alter the tone of the upper airway. So if you have documented OSA before, you remove the tonsil adenoids, you follow up this child, you repeat a PSG. If the OSA is still persistent, this is a child who needs a CPAP. So therefore, it is always better to do a sleep study before removing tonsils and adenoids.
Thank you, ma'am. Thank you, ma'am. Indu ma'am, your presentation is like a precious Hyderabad pearls for us. Thank you for your wonderful presentation, ma'am.
Thank you so much for inviting me once more.
Thank you. We'll go ahead with the next session. It's an important session and eminent speaker, Dr. Deen Dayal Garu. It's a pleasure to have him today, actually, on being Sunday. Thank you, sir, for being with us. Dr. Deen Dayal Garu is the first ENT surgeon in India to use radio frequency in ENT surgeons since 1996. He is the first ENT surgeon to perform silendoscopy in South India. And he's been a guest faculty in cadaver dissection courses, live surgical workshops, and conferences. His books are published on snoring and obstructive sleep apnea, title Management of Snoring and Obstructive Sleep Apnea in 2022, published by Springer. And he has been awarded Bharatiya Chikitsak Ratna Award in July 2010 by Council for Economic Growth Research, Mumbai. Thank you, sir. Good morning, sir.
Good morning. Thank you very much for your kind presentation. Oh God. Are you able to see my slides, please?
Yes, sir. Yes, sir.
Just having it a little issue here. I hope. I'm sorry about it. I have an issue with my slide here. Oh, my slide is stuck. I'm going to exit and come back, please. If you don't mind, my whole thing is stuck.
No problem, sir.
Actually, if you just click on it, it will start moving. Click on the center of the slide.
Click on the center of the slide.
Yeah, it will start moving because we have kept it open for long, it gets hung.
Ah, thank you. Thank you. Thank you very much. Back up.
Please share your slides first.
Yeah, I'm going to share my slide.
And then click on the center.
It's not coming. You know,
Put it on the slide show first and then click on the center of the slide. Put it on the slideshow.
Slideshow. Down. Ah, yes.
Yeah, you have to click on it once more. No, it's not happening.
I'll just exit for a minute, please. I'm sorry. Been there for a long time.
I think while we are waiting, and I ask Dr. Indu a question.
Yeah, sure.
Dr. Indu, now I think you're running a sleep lab. Until from what age are you able to successfully do the sleep studies in children?
Okay. So I typically do not like to do sleep studies in children below the age of 6 months. Okay. And the reason why I don't want to do it is because the EEG patterns in small children are not, they are still developing. So only by 6 months of age, we can actually decipher that this is the stages of sleep can be very easily deciphered. But though internationally, sleep studies have been done in preterm babies in the NICU, etc. So it's not that it can't be done. Comprehending and analyzing them is a little bit of a challenge.
Okay, thank you.
The youngest child that I have done is 6-month-old is a Pradhavili, and this is the child who needed to be on growth hormone, and therefore we had to do it. So, but we still wait for them to become 5 kg and around 6 months of age. That's the time we would do it. Even the belts, the thoracic and the abdominal belts do not fit small children. So we cannot get those respiratory, movements that way.
I mean, how do these kids manage to keep all these probes and things like that?
So, before doing a sleep study, we sensitize the child and the parent. We talk to them about it. I share a small video with them. They go through it. So many children do tolerate it, and sometimes if they just don't tolerate, we move from a full polysomnography to a cardiorespiratory study. So when you do a cardiorespiratory study, all the head channels are gone. So you just have some here, and that becomes easier. The biggest challenge is in children who are not, means children who are Down syndrome or who are mentally challenged. There it becomes a problem. And so they keep pulling out the leads, and that's the place where the technician helps us, and he keeps pushing it back. It's another big challenge is to keep the mother out of it, because when she comes, she has her own ways. No, I can put my baby to sleep, and she will pat the child, and that will affect our sleep study. So that also becomes a challenge. So it is a challenge. So sometimes a sleep lab, running a sleep lab also means less sleep for me. It does happen.
Thank you, ma'am. Thank you.
Yeah.
It's a great service you're doing. Thank you.
Yes.
Can you see my slides, please?
Yes, sir. Yes, sir.
Yes.
We can see, sir.
Yes, sir.
Good morning. Good morning. At the outset, I would definitely like to thank the Indian Academy of Pediatrics Twin City branch, the governing body, for asking me to be a part of this symposium. Special thanks to my dear friend, Dr. Sanjay Bhaskar, President. And I would, I think, without wasting much time, start off with my talk. Oh my God. Yes.
Yes. Thank you, sir.
See, if you're looking at the American Academy of Pediatrics, it talks in terms of a word called sleep disordered breathing, and where there is a partial upper airway obstruction or a complete intermittent obstruction. This part has been already discussed very well with my previous speaker, Dr. Indu. But here I only want to stress on 3 points: simple snoring or upper airway resistance or obstructive sleep apnea come into this spectrum. And it'll be interesting to note that the first case of upper airway resistance was described in a pediatric patient in the year 1982. It was only later on it was found in an adult case. So this is one area we need to understand, that there will be no apneas or hypopneas, but the patient will have excessive daytime sleepiness, and this can be only diagnosed by more than 50% of respiratory events. A successful management of sleep disordered breathing in children depends on accurate identification of the site of obstruction. That is where I would say me as an ENT surgeon am a part of this symposium, because the upper airway is a part of an ENT surgeon in terms of evaluating. Whether you are dealing with a surgical or a non-surgical remedy, this evaluation is important. When you look at the causes in a neonate and an infant, you will always see that these causes are mostly congenital. The congenital part, anywhere from the nose to nasopharynx to tongue to pharynx. And you will also see there neuromuscular disorders. And the minute it goes down to toddlers or older children, that is where the pathology comes in, like rhinitis, polyps, septal deviations, adenotonsillar hypertrophies, and obesity or microglossia. Here, I just want to add an important point pertaining to the etiology of obstructive sleep apnea. There are 4. Number 1, we call it as space-occupying lesions, like adenoid or tonsillar hypertrophy. Number 2 is hypotonia of the muscles. That could be the pharyngeal muscle, the tongue muscles, or the palatal muscle. Or number 3 would be an elongated soft palate, along with the uvula. And number 4 would be nasal obstruction. This is something that's very important, that nasal obstruction is also considered a main part of the etiopathogenesis of obstructive sleep apnea. And nose, it is almost present in 90% of cases. That is a point I'd like to stress about. When you're looking in terms of pediatric OSA, and you will see that it is associated with inflammation, that there is a chronic low-grade inflammation and increased oxidative stress. And you're all well aware about the neurocognitive, the cardiovascular comorbidities, and fragmented sleep and nocturnal enuresis. But this is one part I would definitely like to stress, that whenever you're looking at a case of snoring with obstructive sleep apnea, there should be either a problem in the nose or the nasopharynx, or at the level of the soft palate, or the tongue base or superior hypopharynx, or the larynx or hypopharynx, the complete upper airway. And it will be interesting to note that hardly 10% of cases will have a single level block. Most of them is a combination and it is multi-level. So if you're looking in terms of level 1, you need to view in terms whether the septum is deviated, whether the turbinates are hypertrophied, or there's a large adenoid, or there are polyps that are present. If you're looking in terms of oropharyngeal level or level 2, that is where you look in terms of enlarged tonsils or unusual cases like a lingual thyroid, or like I said, an elongated soft palate with a large thick uvula can obstruct the airway. And in terms of the tongue base, many a time you will see, I'll just I'll just show you how it would be. I'm sorry about this. The enlarged tongue base is another thing. I mean, the video is not playing well. And the level 4 is another part that is missed most of the times, is where you have the problem in the supraglottis or glottis. It could be a laryngeal web, it could be a subglottic stenosis, it could be laryngomalacia, or even bilateral abductor palsies. So these are the things that we need to keep in mind in pediatric age group also. Evaluation has been talked in detail, but I personally feel that from the pediatric point of view, you need to keep in mind a X-ray lateral view nasopharynx would definitely give you the size of the adenoid and even grade it into grade 1 to grade 4. And the second thing is a videotape would definitely give you more information about the child, whether the child is having any apneic spells, whether the child is snoring or not. And you know, cine MRI is there that will tell you about the obstruction. And simple things like BMI and neck examination would tell you a lot of information. And there is a difference of a PSG reading of a pediatric age group to that of an adult. And it is said that even 1 obstruction per hour is supposed to be pathological. That is interesting to note. In case PSG is not available, I think something like putting a pulse oximeter would give you a rough idea whether you're dealing with a case of obstruction. It talks in terms of 3 or more clusters of desaturation, and you would have at least below 90% oxygen. That would tell you that there could be an abnormality. There is a home respiratory polygraphies, and like you know, my previous speaker had said, there is a lot of questionnaires available, and these questionnaires can definitely help the pediatrician in terms of diagnosing. This is a very interesting slide I just wanted to share, that, you know, how can we prevent this? I mean, breastfeeding is now supposed to be one of the most important protective factors against childhood snoring. And they found that those children who were breastfed for a longer period of time did not really have obstructive sleep apnea as compared to those that were bottle fed. And another interesting thing is, shorter the breastfeeding time, there is a higher the possibility that the child could develop a malocclusion and then also have obstructive sleep apnea. I think another preventive part could be maybe to train the parents that in the earlier stage, exercise, diet, and weight loss. And in the clinical practice, to keep in mind about an adenotonsillar hyperplasia, asking in questionnaire snoring and noisy breathing, not to forget to examine the nose for a deviated nasal septum or an inferior turbinate. And of course, abnormalities, but allergy is another part that need to be kept in mind. Quite a few patients of allergy have obstructive sleep apneas. A simpler preventive method is a myofunctional therapy or orofacial myofunctional therapies, where there are isotonic isometric exercises that can be taught to the children that will strengthen the tone of the tongue, lips, cheeks, and throat. This is the one that helps in hypotonia. A little bit about biomarkers. That biomarkers, actually, the ideal one should correlate with the severity of the disease and also indicate treatment response. As of today, there are about 65 proteins associated with OSA that have been marked out. Simpler ones like CRP, because of inflammation, can give you an indication. A word about COVID and obstructive sleep apnea. Both of them are pro-inflammatory. And if there is obesity with severe OSA, the infectivity would be more. And there is a possibility that with severe OSAs, cardiac complications are bound to be more. And also you need to keep in mind a possibility of coagulopathy, an increased risk of pulmonary embolism. And this effect of lockdown and home isolation has definitely increased obstructive sleep apnea cases. So OSA is a risk factor for poor outcome of patients hospitalized with COVID-19. In terms of nasal obstruction, my videos are not working. I'm sorry about it. All my videos are not working. No, I'm sorry. Anyway, this for nasal obstruction, what I wanted to quickly put across over here is that if there is a deviated nasal septum, previously they would say you'll only operate it after the age of 15 or 18. Today we operate septal surgeries even at the age of 4 and 5. Inferior turbinate can be beautifully reduced. Coronal atresia, even if it is unilateral, has to be corrected. And if there is an antrocoronal antronasal polyps, they need to be operated and removed to improve the nasal airway. Nasal airway is one of the main reasons for obstructive sleep apnea. Similarly, an adenoid hypertrophy that is present, like it has been put forward, grading of an adenoid hypertrophy may not be the only reason for obstructive sleep apnea, and hypotonia can be. But if it is a large space-occupying lesion, it needs to be positively removed. And that would grossly improve the patient's quality of life and symptomatology. Now coming to the level 2 surgeries like tonsillectomies, there are different ways of doing. Any tonsils that are obstructing the oropharyngeal airway should be removed. It is not only that, if it is an elongated soft palate that is obstructing the airway, to do a palatopharyngoplasty in a child would definitely benefit the child. Coming to a word about macroglossia. There are quite a few obese children with large tongue bases, and there are quite a few children with large lingual tonsil. So lingual tonsils have to be removed. And if the tongue base, which is muscular and large and collapsing, we need to reduce it. And in younger age group children who have a hypotonia where the tongue base falls back, a simple thing called as a suturing of the tongue anteriorly, which can be reversed later on. This type of a procedure can be done in pediatric age group. Now coming to the level 4 part of it, see laryngomalacia cases where even with your conservative treatment, if it is not getting all right, these two procedures, glossoepiglottopexy and supraglottoplasty, this is where the results are excellent. They are as good as 100%. Something like laryngeal webs or stenosis, bilateral abductor palsy, all these surgeries are recommended. syndromic children, this procedure of mandibular distraction has done wonderfully well in terms of surgery. And babies who are suckling, if the tongue falls back, a labioglossopexy can definitely help these children. Whenever there are multiple obstructions and the child is finding it difficult to thrive, a tracheostomy is the order. A quick look at the evidence-based studies in pediatric cases of OSA. If you look at this particular paper presentation, infection and allergy are risk factors in pediatric OSA. So anywhere there is sinusitis, nasal obstruction, nasal part of it, correction of nasal surgeries definitely help the pediatric age group. This is another case that talks about the nasal obstruction that would definitely help out. And if you're looking in terms of cardiovascular parameters in children, improvement where there was obstructive sleep apnea and surgery was performed, there is evidence that all the cardiovascular comorbidities associated with OSA were reversed. Another documentary evidence that talks in terms of patients who have had, like, when you're picking up patients with severe morbid obesity, Down syndrome, cerebral palsies, these type of cases, adenotonsillectomy, uvulopalatopharyngoplasties, and also patients with asthma, they have found that definitely there is an improvement after surgery. So quickly to conclude, according to the American Academy of Pediatrics, if a child is determined to have obstructive sleep apnea syndrome and a clinical examination consistent with adenotonsillar hypertrophy and does not have any contraindication for surgery, the clinician should recommend an adenotonsillectomy as the first line of treatment. So that is the most important thing, because there is always a gray zone telling, does this patient really require? So if you feel that they have obstructive sleep apnea and there is hypertrophy of tonsils and adenoids, the first line of treatment is adenotonsillectomy. And if the child of OSA and does not have adenotonsillar hypertrophy, then other treatment should be considered. Clinical judgment is required to determine the benefit of adenotonsillectomy compared with other treatments, because the children are obese and they have other reasons for having obstructive sleep apnea, like hypotonia and of course obesity. So to conclude, correction of nasal obstruction would improve the compliance of either a CPAP or would definitely improve the symptoms of the patient. So that was one important point, that even in pediatric age group cases, nasal obstruction need to be corrected. Secondly, that severe tongue-based obstructions are many a time overlooked, especially in obese patients. And these, if corrected, they grossly improve in terms of their symptoms. And here again, tomorrow, if you want to put the patient on a PAP therapy, that would definitely help the patient. You should always keep in mind that there is a level 4 obstruction, that is at the level of glottis, supraglottis, and a little bit of subglottis. And that is where you have to keep in mind that if your PAP therapy is not helping the patient, that maybe you're dealing with a level 4. That is one thing that you have to keep in mind, and that definitely requires an ENT checkup completely. If somebody asks you that, is there any surgery that gives you 100% relief from obstructive sleep apnea, I would say it is only tracheostomy. No other surgery would give you 100% relief. It would be to a greater extent anywhere from 70 to 98, 99%, but 100% is only a tracheostomy. And the last couple of take-home points before I close is regarding prevention of obstructive sleep apnea, that if I see an adult obstructive sleep apnea case, I personally feel if that was diagnosed in childhood and if it was properly managed, that person would not have developed adult obstructive sleep apnea. So we need to view in terms of prevention and give a lot of importance, even if there is the slightest indication towards an obstructive sleep apnea. You should be very, very forceful in your management, trying to educate the parents about it, and also to help the child out to come out so that in adulthood, they don't suffer a lot. Thank you. Thank you very much for your patient listening.
Thank you, Dr. Deendayal Garu, for your wonderful presentation and enlightening with your wonderful, great knowledge. Thank you, sir. Thank you very much, sir. Any queries? Please put it in the chat.
Should I ask or should I put in the chat box?
Yes, please.
Okay.
I think you can ask Dr. Indu.
Dr. Deendayal, thank you for a brilliant presentation. I mean, absolutely enjoyed hearing you.
I feel bad that this, I had some problems in terms of running the thing, but it's perfectly fine.
I wanted to ask you, we are seeing younger and younger children now with adenoidal hypertrophies. We are seeing children with younger kids with allergic rhinitis, because earlier the saying was that the body has to get sensitized and then only the child's symptoms of allergy will come. And just generally they say it doesn't happen before 3 years. Most of the nasal corticosteroids which are given are not cleared for use below 2 years of age. But we are definitely seeing younger children because of pollution or variety of reasons. That I don't know. There could be a lot of many reasons. So has the age for adenoid removal come down? And if so, is it safe to remove adenoids at a younger age?
Yes, I think that's a nice question. I'll definitely answer that. As far as possible, I do not operate till the age of 2. Ideally, I would prefer anything after 2.5 years of age. Second important thing, I like my patient's weight to be in a 2-digit, 10 kg and above. I don't like it, but there are some patients who find it very difficult to thrive. They are not able to drink because of this thing. And that combination of adenoid hypertrophy and allergy seems to be the in thing as on today. Quite a few patients come and the parents are so worried because they're finding it difficult to breathe. I have observed in these cases that even though, like you said, mometasone nasal spray is advised after the age of 2, that there are some cases I have put them on mometasone, maybe at about 1.5 or 2 years, but the patients have shown an improvement along with saline washes. This is one thing, conservative management, which I have been doing. And those patients who have not responded well, yes, after evaluating, to remove their adenoid. And in these cases where their turbinates are hypertrophied and collapsible because of the allergy, we do a very simple thing called as radiofrequency channeling. The minute we channel it with radio frequency, the whole turbinate collapses. And the nasal airway is so beautiful that the patients are comfortable, and it improves in 3 ways. Nasal breathing. Number 2, nasal discharge comes down. And 3, interesting part is these patients also have sneezing. And the sneezing part is mainly because the maximum receptors are on the inferior turbinate. So now that you have reduced the inferior turbinate, the sneezing will not disappear, but at least it will come down by 30 to 40%. So that way they are happy.
And following on from Dr. Indu's question, we see adenoid hypertrophy even in infants when we're doing bronchoscopy for a different purpose. I mean, even in 5, 6 months, how early can you see adenoid hypertrophy in babies? What's your experience?
Adenoid hypertrophy in children if it is large, like grade 3 and grade 4, that means that they are either partly, responding to their immune system. They are supposed to be, adenoids are supposed to be big at that time. And these patients with large adenoids, it's 6 months, 8 months, 9 months, which are not complaining, and the parents don't complain, they don't have much of a sleeping problem or feeding problem, I would say leave them alone. The only thing I would only try to push it as far as possible if I have to do a surgery beyond 2. And till then, I'll only do a conservative management, like douching is one common thing that we are doing. And of late, there is a little bit of a hypertonic saline that has come into the market. A hypertonic saline is supposed to decongest the nasal mucosa and create an airway that is a little better. Maybe you can take a try at that. I will not suggest that young age for any steroid sprays or never xylometazole, never.
But this septal surgery and adenoid surgery are doing as young as 4.5 years.
Yes, my youngest is 4 years old.
Okay, sir. Thank you. Thank you very much for an excellent talk.
Thank you, Doctor. Mesmerizing talk.
You can ask your question. Last question.
Yes.
Last.
Yes, please.
Thank you, Doctor, for mesmerizing with your informative talk. And thank you for being with us today. With this interesting.
Thank you very much for the opportunity. And thanks to my friend, Dr. Bhaskar again. Thank you.
Thank you. Next interesting session, Dr. Suman Kumar will take over as moderator.
Yeah. Thank you. Am I audible?
Yes. Please go ahead.
Okay. Thank you. I think I should first thank the faculty for waiting so long. I've taken away their Sunday. Please don't curse me for that. And thank you for cooperating. And Indu, you have become a host of this session. We have become muted and you have become more active. Thank you for being a part of this session. And without wasting further time, we are already late by almost 40-45 minutes. So I would start off with interesting cases of pulmonology. So first introduction, there are 4 faculty with us who are already with us. And the new faculty would be Dr. Samya Razvi, and followed by Dr. Indu, Dr. Suma Shivalan, and Dr. Srinivas Jekka. Dr. Samya Razvi is a consultant pediatric pulmonologist. She's heading Department of Pediatric Pulmonology at Apollo Hospital, Jubilee Hills. She's completed her DCH from CMC Vellore and a 3-year MD Pediatrics from New York. And then they did her Pediatric Pulmonology Fellowship from Columbia University. And then did her MS Biostatics from Columbia University, New York. And she also worked over there for a certain period of time before heading back here. And Dr. Samya Razvi and Dr. Srinivas Jekka have been heading the Department of Pediatric Pulmonology for quite some time now. And if I can see, because there's not much of interaction with her, but as far as I know, I have seen her documentation with what cases she sees. She is very meticulous in her case presentations in whichever cases she sees. Her documentation is quite meticulous. Her history taking is quite meticulous. Her case sheet runs up to 2 to 3 pages, any OP sheet which comes there. And that shows, how much of a clinical approach she has got towards her patients. So I believe she has got some quite interesting cases with her. She would be going through her cases, and then we would be asking questions on a pediatric point of view, what else we could do and what else we could approach. Dr. Samya Razvi, I think I'll be stopping my screen space here. Just before that, I will introduce other speakers. Actually, they have already introduced, but I will add a few points to my side. Dr. Indu, you have already been seeing her for the last 1 hour, 2 hours or so. As far as I know, she's a gold medalist right from childhood. She has received only gold medals. She doesn't appear like that. She's quite friendly, and she's been very good as far as an academic front. And she's been at a faculty in the national level and international level as far as pediatric pulmonology. I've been lucky to attend most of the sessions, both nationally and internationally. Very good speaker. And when I have asked her to give a presentation on sleep, she said I can even talk about it in sleep as well. So she's so much into sleep. So I believe she has got some interesting cases of sleep studies. I think that's an interesting topic because we brought this sleep studies because sleep as a topic, because this is something which we pediatricians should be enlightened. because patients do come and complain to us in this generation that, the children are quite irritable, they're quite angry, they're quite annoyed, they are not performing well, their memory is going down. And obviously, the pathological reasons are also there. And we actually are not looking at that. I believe, this day today, because of these presentations by these wonderful people, I think we would be enlightened on this angle as well. I think she would be presenting some challenging cases in sleep studies, and then it will be followed by another exciting speaker. Here is a person, who is not only very good at academics, but he's one person who has run marathons across various continents. He's run marathons in Africa, run marathons in various other continents, and he does 10,000 skips in a day. And he still is a very good academician. He's none other than Dr. Suma Shivalan. Thank you for being with us, sir. You're a very friendly person, and I really thank the patient despite the schedule they have taken a Sunday for us. And he's got very good, exciting cases, cases where we can have a good discussion on. And then followed by our own Dr. Srinivas Jekka, who has been spearheading pediatric pulmonology in Hyderabad, who has done his fellowship from UK and has got experience from Singapore. And he's also an expert in pediatric allergy and bronchoscopy. Thank you, Jekka, for being here. And without wasting much time, I think I will be stopping my screen share. Dr. Samya, you can take over.
Sure.
You can share your screen, please. Dr. Samya, are you there?
Yeah.
Yeah, please.
Just sharing it here right away.
Thank you.
Are you able to see my slides now?
Yeah, I can see you. I can see your slides.
Okay. Shall I just make it a slideshow?
Yeah, you can make it into your full screen.
Sure. Okay, so good afternoon, everybody, and thank you for the invitation to speak here today. And thank you for the introduction, Dr. Suman. And interestingly, I have included a few screenshots of my case presentation. So I thought for this invitation to talk on challenging cases, I thought I'd share two of my patients who have been following for the last few years. And I was asked to speak on the topic of recurrent pneumonia or recurrent lung infections. So I thought that I would focus more on the clinical scenario, the decision-making process that goes in your thoughts as you see a patient in your clinic. What are the red flags that would come to your mind, and how would you do the basic workup and follow through? So I wouldn't focus much on management. And I just wanted to list some of the common clinical scenarios for which I get referred a patient, or which you definitely see many times more in your practice. The scenarios in the neonatal period are often there's a term or a preterm baby who may or may not have respiratory distress at birth. They may have patchy infiltrates on X-ray. They may require ventilatory support or surfactant. There might be a failure to wean from the ventilatory support, either HFNC or intubation. And once even that is done successfully, after a period of time, the child goes on to become oxygen dependent with a small amount of oxygen. And there's a prolonged NICU stay. And often that's the point at which the referral comes in, or the pediatricians or the neonatologists are handling that baby and are faced with this scenario. That's one set of patients we see with recurrent infections or lung infections or recurrent pneumonia, if there's infiltrates on the X-ray. Other than that, in the infancy or infant period, you see babies that may be well at birth, go on for the first 5-6 months of life, maybe the first winter of life. They might be admitted with an episode of bronchiolitis, discharged, healthy, striving, gaining weight, and then they get admitted again with distress, hypoxemia. So there might be a proven bacterial or a viral infection. There may be a normal X-ray or not, but these are babies that are then termed as recurrent wheezers or recurrent pneumonias. And that's another group of patients. In the slightly older age group, we see toddlers who will have cough and wheezing episodes as they face viral infections and bacterial infections, starting to go to school and preschool. And their symptoms and cough and wheeze may or may not clear in between the episodes. So there becomes a fine differentiation there. And these children, again, the bottom line always in pediatrics is the child thriving? And that's a theme that will come through, I think, in the next two patients which I share. Then going on to just taking any age group, any child in our pediatric practice who has frequent respiratory symptoms, we look at whether they are having a productive cough or a dry cough, they've been hospitalized or not, whether the X-ray or CT has shown changes. Of course, I don't prefer that CTs are done often, except in the rare situation because of radiation exposure. But again, the bottom line here is the child thriving or not doing well, and are there other systems involved? So when we talk about respiratory infections and recurrent lung infection or recurrent pneumonia, there's a lot of terminology which all of us write in our busy clinics. But the definition becomes important when you're looking at recurrent versus persistent. So persistent by definition is when a clinical or radiological lung infection or pneumonia or lower respiratory tract infection is persisting for more than 4 weeks, And we all know that radiological lag is a little longer than clinical improvement. Recurrent pneumonia is defined as at least 2 episodes of pneumonia or LRTI or pneumonia clinical or radiological in a year, and maybe more than 3 in a lifetime or at any period of time. So keeping that in mind, I chose these 2 patients of mine that I've seen from early infancy till about 5 or 6 years of age now. And these patients were challenging because for the pediatrician it's challenging when you're handling them as the first point of contact care. The patients are coming back to you repeatedly, or you're stuck at a particular point in their care. It's also challenging to come to a diagnosis. I mean, what test do you choose? How do you prioritize your testing? And then once you've made a diagnosis, the challenge is in follow-up adherence to the plan, where you really need the parents and the families' support in these chronic illnesses. So I've taken permission of both of these parents to present their children and their data. So the pictures of the children are here and their information. So the first patient I'd like to mention is this baby who is now 6 years old. She was born at term with a birth weight of 2.85 with a good APGAR score 9 and 10 to an O negative mother. The baby was DCT positive and direct Coombs test positive and had jaundice and required some prolonged phototherapy for till about age 10 days. Around that time, when the jaundice seemed to be settling, because this was a breastfed baby, the baby developed a cough. And they also noticed that the baby had not gained weight. So they thought it was due to the hospitalization and the 10 days in hospital and the phototherapy. But this cough persisted. And then about 1 month of age, this baby had a cold, fever, rash, and even peripheral cyanosis, which was quite scary. The baby was hospitalized emergently. And the chest x-ray showed a right upper lobe pneumonia. There was no oxygen requirement, and the child was treated with some antibiotics, IV. And since there was no oxygen requirement, unfortunately, the parents went against the discharge against medical cough, deep cough, bouts of cough, and the baby was hospitalized again at 1.5 months of age. This time required some oxygen, given IV antibiotics. I have not mentioned it here, but the right upper lobe pneumonia was persistent. There was some infiltrates. And then when the baby seemed a bit stable, was taken home again, but readmitted for the 3rd time. And this time, the baby was in more distress. The infiltrates were more, the oxygen requirement was more, and then this baby was transferred to a higher hospital where the baby got intubated and mechanically ventilated. ET cultures at that point showed Klebsiella acinetobacter, which could have been due to the previous hospitalizations, could have been nosocomial. The blood culture also grew Mercer, of all things, whether it was a surface contaminant, entered the bloodstream. The child was quite sick. The 2D echo just showed a PFO. And the attending neonatologist, who was still a neonatologist at that point, at the 3rd hospital, did a CT chest, which showed this consolidation of right upper lobe and hyperinflation, some patchy infiltrates. I was involved in the care of this baby around age 10 weeks when the baby was still inpatient, had a persistent deep cough, oxygen requirement, distress, and was not able to establish oral feeds and was still stuck on orogastric feeds. The chest x-rays, as I mentioned, had this patchy consolidation and the right upper lobe opacity. So at this point, this X-ray, as you can see here, showed the hazy infiltrates. The second X-ray was actually the patient's X-ray. The other 2 are images off the internet because this patient had submitted the radiology images for insurance and funding. Shows patchy infiltrates and a basilar hyperinflation in the second X-ray. The CT scan is just for illustrative purposes to show the dense consolidation in the right upper lobe. You know it is a right upper lobe because you're seeing the shadow before the bifurcation of the trachea. So this is just a scan of the notes that I had made at that visit. I'm surprised that Dr. Suman commented on my notes, but just shows that the important point here, apart from the previous hospitalizations, was there was a history of a sibling death, and there was these hospitalizations that were serially going on, and the parents were quite at the end of the tether. But interestingly, this was the discussion I had with the attending pediatrician, and he had astutely sent off a cystic fibrosis screen, as well as we were giving high-grade antibiotics. We had screened the baby for immunoglobulins, for immune deficiency, thought of a ENT evaluation to rule out any laryngeal cleft or any right upper lobe bronchus abnormality that was causing this persistent opacity. And also, since the baby had not established feeds, the consideration was whether this baby would ultimately require gastrostomy tube. So just to look at the thought process that we were facing here, for this persistent consolidation, in any child with a persistent consolidation, you're going to be thinking about whether it's a drug-resistant bacteria with this prolonged stay, some atypical pathogens, whether it could be even congenital tuberculosis or tuberculosis, fungal infections due to broad-spectrum antibiotics, whether there was a mucus plug causing atelectasis and consolidation, whether there was a bronchial abnormality like a pig bronchus which was occluded, whether there could be a congenital lesion like a congenital pulmonary adenomatoid malformation or a sequestration, unusual in the upper lobes, usually in the lower lobes. Could there be a H-type T fistula with aspiration? Could this baby just be aspirating due to discoordination of swallowing because of neuromuscular weakness, prolonged ventilation? All these thoughts went through mind. And then immune deficiency, which again at 2 months, 3 months would be quite sinister because the baby still has passive antibodies from the mother till about 4 months. So at 2 months, you're looking at combined T cell and antibody and T cell combined effects. Cystic fibrosis, we always think as rare, but nowadays I see a lot more awareness in pediatricians, and ciliary dyskinesia, which is also rare, but not uncommon. Underlining all of these issues with the recurrent or persistent pneumonia that this baby had and the multiple hospitalizations was the poor weight gain. Baby was still struggling somewhere at 2 months, just beyond birth weight. So the reasons for this poor weight gain could have been the chronic infection, the catabolic state, increased needs, maybe the prolonged antibiotics. There was some loose stools which was attributed to the antibiotics. Maybe the orogastric feeds were interrupted. Hypoxemia could be contributing to the poor growth. So all these thoughts were going through my mind, and the attending pediatrician, who was quick enough to have sent off the cystic fibrosis screen with 4 mutations, which came back while this baby was still in the hospital. And the baby was homozygous for the Delta 508 mutation, confirming the diagnosis of cystic fibrosis. So at this point, looking back, the flags or the points that were interesting was this mother clearly reported that this baby's cough had been persistent, never subsided since the age of 10 days. There were changing infiltrates, the chest crackles and exam had never cleared. There were thick secretions when this child had been briefly intubated. There was hyponatremia, which was thought secondary to the pneumonia, like an SIADH picture. There had been loose stools, again, thought due to the antibiotics or hospitalization, and there was hypoalbuminemia, which, as we'll see, is a flag isolated sometimes for cystic fibrosis. So knowing that cystic fibrosis, knowing that for cystic fibrosis, nutrition is the most important factor for lung health and outcomes. This was the baby at age 2.5. No, this was actually around 3 to 4 months age, where the baby was gaining weight due to the care of the mother. As you can see, the baby still had an OG feed at discharge, looked otherwise healthy. And we proceeded to go ahead with the PEG tube placement, which the child still has to this day. The picture on the right shows the child at age 6 when she recently had the size of the PEG tube upgraded because she's grown in size. So this baby also had a bronchoscopy right in the immediate infancy period while she was still hospitalized. It ruled out any laryngeal cleft or T fistula. And we did get some secretions that grew, again, gram-negative bacteria. I think it was E. coli that time. She was treated with higher grade antibiotics because most of her bacteria, Acinetobacter, MRSA, were drug resistant, having received multiple hospitalizations. And following the PEG tube insertion, she had G-tube supplements. We persisted with swallowing and feeding therapy, and probably around age 12 to 15 months, a child started taking oral feeds properly, but was really dependent on the G-tube from about 3 to 4 months age till beyond the first year of life. A high-fat diet, pancreatic enzyme replacement, fat-soluble vitamins, extra salt, as you know, CF is a salt-losing condition, medium-chain triglyceride oils to improve the direct absorption of fats, and most importantly, a strict regimen, a strict daily regimen of respiratory therapy using bronchodilators, inhaled steroids for the V's, mucolytics, including hypertonic saline, teaching the parents manual percussion and postural drainage. Then as the child grew older, she actually uses an a cappella now at age 6 years, which helps to clear the mucus. And throughout these last 5 years, surveillance has been with frequent sputum cultures, oral and IV antibiotics as required, early aggressive treatment, and a very close follow-up of weight gain. So this picture sent to me by the mother just shows all the medications that the child is on, the inhalers, the vitamins, the supplements. She also faces some issues with constipation. So she's also on stool softeners. She's on fat-soluble vitamins, the whole deal. And it takes a lot of care to bring this child to the picture on the right, which is a recent picture, a healthy, active, 6-year-old, bright, smart, intelligent, and reports her symptoms well, and has been doing very well, all probably due to the mother's care and adherence to follow-up, which hasn't been easy. In the last 6 years, there was a time of denial, there was a time of falling out of follow-up, but then all things come together, she has done well. So that's about cystic fibrosis. We'll touch upon it later. But I wanted to just mention in the pediatric practice, the red flags that should alert my mind or anybody's mind for CF, which does exist in India, as you have been seeing in multiple webinars and talks. In the neonatal period, it's a given that if a child had a meconium ileus or had a delay in passage of meconium peritonitis, perforation, and ileostomy for any reason, prolonged neonatal jaundice, this must be considered as CF unless it is ruled out definitively. An elevated IRT that we see on newborn screening tests is not diagnostic, it's just a flag, and the child will require a final definitive test like a sweat test or genetics. Cough that does not clear, an old man's cough, a persistent deep cough, bouts of cough that make the child turn really uncomfortable and red in the face or blue in the face. Failure to gain weight just by itself, because 15% of children may be pancreatic sufficient and they may or may not have loose stools or diarrhea, but they will have salt losing, they might have failure to gain weight. Hypokalemia, hyponatremia, and dehydration episodes in summer we see in the south in the extreme heat. Sometimes that goes on the side of a renal diagnosis of a Barter's syndrome or some other nephrology complaint, but cystic fibrosis must be kept in mind for episodes such as these. Isolated hypoalbuminemia, we diagnosed 2 infants in the lockdown who just presented with lower limb edema and a low albumin, no respiratory symptoms till age 8 to 9 months. If Pseudomonas is isolated anytime from the respiratory tract, either from the sputum or bronchoscopy sample, it stays as a pathognomic sign of CF, and CF must be ruled out. For prolonged hospital stays in children with bronchiectasis, Pseudomonas may be a contaminant, but still it is worthwhile in children with bronchiectasis and Pseudomonas isolation to make sure that there is no CF. Nasal polyps in your clinic or practice, I heard in the talks of adenoidal hypertrophy, turbinate hypertrophy, sometimes chronic nose block, nasal polyps that are diagnosed by ENT, they certainly warrant ruling out of cystic fibrosis. Bronchiectasis discovered in an older child or younger child on imaging, also maybe for multiple reasons, could be post-infectious bronchiectasis, it could be due to a foreign body, but if there's bronchiectasis and some of these attendant signs of failure to thrive, some diarrhea or not, and then these kind of flags for the child looking back through the history, CF must be considered in any child with bronchiectasis that is otherwise unexplained. So keeping that in mind, so that patient with recurrent hospitalization, I'd like to just talk quickly about another patient who was also a full-term baby delivered with a similar birth weight of 2.8 kilos, breastfed with a good feeding, good suck and swallow, and a fair weight gain, no diarrhea as such, but hospitalized multiple times starting from the age of 6 months for wheezing and respiratory distress. Every admission showed cough, wheeze, crackles, tachypnea, hypoxemia, and he needed high flow nasal cannula a couple of times. I think he was hospitalized about 6 times before I saw him, and he was never intubated. The chest x-rays serially showed patchy infiltrates. There was never any major consolidation or collapse. There was no bacteria isolated in cultures in all of those 4 or 5 hospitalizations, I can't recall. He seemed to respond better to IV antibiotics than oral, did not really respond to steroids for the wheeze, and he was always readmitted within 2-3 weeks of discharge each time. And these parents lived in a town, actually almost 6 hours from Hyderabad, and each time they were rushing to the hospital and to the city for admission. So this was one of the x-rays of the baby that showed these patchy infiltrates, unremarkable normal cardiac size. And going back again into the history, and you'll realize some of the negative history is important here, that this baby did not have any rashes, eczema, skin infections, or abscesses that would kind of suggest atopy or some immune deficiency. The baby did have nasal discharge with illnesses, but there was no ear discharge. There was no cough or choking with eating or drinking. The stools were normal. In fact, there was mild constipation. There was no diarrhea. There was mild motor developmental delay. He had a head control at 6 months, sat up late, walked late, no seizures, otherwise bright, alert. And there was no family history of sibling death or asthma. There was no exposures that we could identify. In each of those hospitalizations, the counts were usually normal to elevated, mildly neutrophilic. The CRP would be very mild. And one of these admissions, he was positive for influenza A. The CT chest that he had showed bilateral patchy segmental consolidation and early bronchiectatic changes. But again, a CT chest, just to put in a point here, is not I mean, can be done. I really think a CT chest should be saved for two occasions, either if the child is not getting well and getting worse, but in a child such as this, doing a CT chest when he's symptomatic with just one more respiratory infection, we're really going to get non-specific findings. So a CT chest is best saved either when you're facing a clinical situation where child is getting worse before your eyes and you have no idea how or what is happening. That's one time. Or the other time to get the CT chest is when the child is actually at his best and not in the middle of a hospitalization. So you can get an idea of the basic parenchymal structure and the bronchial anatomy. This child also had a grade 2 reflux that was worked up by the pediatrician. 2D echo was normal, and similar to the other child, the immunoglobulins, thyroid, renal function was normal, and a CFTR4 mutation screen was normal as well. So, sorry, 1 second. So when you looked at some of his x-rays, what was notable was the infiltrates were bilateral, usually basal. They were changing in location. They were not in the same anatomical area. And there was hyperinflation, which was suggestive of small airway obstruction in the lower zones. So one of the points here, which was very similar to the previous patient, was the mother said that he always had a little cough. He never really cleared the cough in the last 3 months before I saw him. And even in his sick visits, when he had omnicortal, the cough and wheeze did not clear. So that was just something to keep in mind. And here again, the pediatrician had sent off the clinical exome sequencing despite the 4CF mutation screen being normal, because as I mentioned, this child was struggling with 6 hospitalizations, traveling to the city each time. And so in the interest of the situation, and despite the cost of a clinical exome sequencing, which runs from maybe 15 to 20,000, it was thought to be worth it for this child. The other thing that we needed to consider in this child was, as I have flagged on the left side, the hypotonia and the developmental delay, whether that was a reason for his poor cough reflex, ineffective clearing of secretions, or some swallowing disability which we could not pick up that was causing recurrent aspirations or reflux with aspiration. He did have grade 2 reflux. So we put him on a good regimen of saline sprays, Montelukast for the wheeze, Budicort, Levolin. This is one of the acute visits that I saw. And I also put him on some azithromycin at that point as an anti-inflammatory for a longer period, for about 2 to 4 weeks, just because we were at a dead end where he was getting hospitalized every 2 weeks following discharge. So the clinical exome sequence, which was sent by his pediatrician, came back as homozygous for 2 mutations for ciliary dyskinesia on exon 15. So this was the diagnosis that was confirmed. And in primary ciliary dyskinesia, much of the treatment or management is supportive as for recurrent respiratory infections as in CF. And similar to CF, it's important to suspect the diagnosis early, check the ears and sinuses, which are sometimes a giveaway with draining ears or sinuses, screen for immunodeficiency as was done, look for atopy, sputum cultures to direct antibiotics, early antibiotics for infections. Even if you have to use it multiple times, directed by sputum cultures as possible, early antibiotics, aggressive chest physiotherapy, and as for CF2, nutrition and vaccinations are important. The specific diagnosis for ciliary dyskinesia are not easily available. Genetics that we have today picks up about 40 mutations, expensive study. The true studies such as ciliary studies for live ciliary biopsy from the nasal passages or the trachea with electron microscope, not easily available. So we still go with genetics as far as possible, but there may be mutations, sporadic mutations, which are not picked up on the current genetic screens. So this is again another picture just demonstrating how even in a remote area, this mother who has taken excellent care of this boy, this is a picture that she sent me just day before yesterday of how he is today at 6.5 years, happy, well grown. And luckily during lockdown, both of these children have done fairly well. So the red flags for ciliary dyskinesia, just to make a slight difference from cystic fibrosis, even though cystic fibrosis, children may have nasal polyps and sinusitis, chronic nasal stuffiness, yellow crusted nasal discharge or ear discharge, shifting and atelectasis collapse on x-rays in the neonatal period and infancy, and in association in 50% of the cases of ciliary dyskinesia, there might be dextrocardia or situs inversus. Recurrent infections in these children are more in the initial early periods with H. influenzae, strep pneumonia, staph, the usual ones. And later, if they have had multiple antibiotics, they may also have other gram negatives, but less common until they're much older. And chest X-rays usually show bibacillar infiltrates, and the CT scan may show the same thing. So if there is a minute or two, I'd just like to, do I have some time for a few minutes more?
I think you can finish off with this slide, Dr.
Okay.
Sanjay, so that
Okay, sure. So in recurrent pneumonia, just as everybody knows, just the highlight here is whether it's in the same location or different locations. Same location, two things: structural or congenital lesion, making that part susceptible to mucus plugging and pneumonia, or an airway foreign body. Again, bearing in mind that some of the airway foreign bodies can shift from one side to the other side. So same location or different location can hold true for a airway foreign body, a chronic airway foreign body. Different locations, immune deficiency, aspiration, and these two patients that I mentioned, CF, ciliary dyskinesia, and even congenital heart disease that can make them prone to recurrent pneumonias. The differentials, as we went through, similar again, so I won't go through this list. And the basic workup, as in pediatrics, which in both of these cases was dealt by the pediatrician successfully. Small flags are that in the CBC, you might see lymphopenia in an immune disorder. You might have a slightly elevated CRP in acute conditions. The ESR may be chronically elevated. Sputum cultures should be sent. I see a lot of babies that have been intubated for infections or pneumonias, and somehow the endotracheal aspirates are not sent consistently. I mean, that's a golden opportunity if you have an intubated baby to send an ET aspirate for culture, even if the baby is on high-grade antibiotics. Immunoglobulin panel can be done easily. A T-cell panel requires a little bit of expertise in the flow cytometry, so that can be done at a referral center. The highlighted yellows are what can be done easily by a pediatric practice: a 2D echo, an upper GI study, a swallowing evaluation done by certain specialists in ENT, where there was scopy as well as a functional evaluation of swallowing. The 4 mutation CF screen is easily available. Genetic studies are also available. A sweat test remains the gold standard. And CT with contrast or CT angio, again, better saved as a second level. You do not want to waste your opportunity doing the CT because of the radiation you do. So working with the X-rays and saving the CT for the right timing is important. So I think I'll stop here and
thank you, Dr. Sanjay. I think the cases were quite interesting. If you look at the first case, the amount of medications which a cystic fibrosis child has to take in her lifetime in order to keep herself going is something of a surprise, and still the parents are quite positive about it. Now, the first question for as a general pediatrician, whenever we face these cases of recurrent pneumonias, would be, when do we actually suspect cystic fibrosis in children? On an average, see, we can't diagnose cystic fibrosis for a unknown history at a child of 6 months or 7 months, even though the child would be suffering. When would we think an earlier stage to suspect a cystic fibrosis?
So I think the history is important, but as you said, looking at it age-wise, in the neonatal period, any child with a delayed passage of meconium or an ileostomy for whichever reason, there might be a necrotizing enterocolitis and the baby ended up with an ileostomy, or a Hirschsprung's and had an ileostomy, but an ileostomy or a meconium passage delay is one thing in the neonatal period. A chronic cough which never subsides is one flag. Pseudomonas isolated at any time, and failure to gain weight, failure to thrive. Even sometimes you've seen short-stature children with clubbing, which is another indication of a suppurative lung disease. So neonatal period, chronic cough, clubbing, failure to gain weight, short stature, diarrhea may or may not be there, but often is there. Parents may underreport it. Pseudomonas isolated from any respiratory tract cycle. Bronchiectasis, which is otherwise unexplained.
And any antenatal diagnosis for cystic fibrosis, because the parents might be carriers, both the parents might be carriers, or earlier sibling might be positive for cystic fibrosis. They're going for a second delivery. Can we diagnose antenatally so that we can plan for the future pregnancies?
Yes, so there are more than 3,000 mutations of CF, and particularly in India, where the incidence of CF is like about 1 in 35 to 40,000 as compared to 1 in 3,000 in the West. Some of the mutations that our patients may have may not be picked up on the genetic panel known as such. But if a child has 2 known mutations, certainly the parents, I have sent 2 of my patients, one of them who is a physician and one of them who's a bank officer. They have had their second children under supervision of the genetic counselor. So it's important to screen the parents, of course, the siblings, to see if the siblings who are well are carriers. And if the parents' mutations are known and the parents progress with the pregnancy, they can have a they can have amniocentesis around 12 weeks, I think 10 to 12 weeks, and they can know the genetics if that particular pregnancy is affected or not. So they can, proceed with the pregnancy. Again, it's a bit tricky, but that's the counseling that the genetic counselors will provide. And both parents have to be carriers for the child to have that. De novo mutations are very rare. So if both parents are carriers and one child is affected, the sibling has 25% chance of being affected, and one of the four siblings, 25% chance, 50% chance of siblings being affected, and one child could be normal, having received both normal, genes from the parents.
I think it's more of a personal decision for a parent to undergo sampling or antenatal screening as far as cystic fibrosis is concerned. Sure. And next would be, what would be the lifespan of a cystic fibrosis? What would be the prognosis of a cystic fibrosis child in your experience, and what would be the average lifespan? Because this is what we know, that there is no cure for this. So the average, what parents would ask is, what is the survival rate of this patient? How long would they survive with the current medications?
Right. It's a very difficult question. And to be realistic, we have to tell the parents that this is a life-limiting disorder. In the West, about 10 years back, the average life expectancy was like 36 or 38. Now it's about 44 years in the West, where they diagnose with newborn screening, they follow up, they have all the ancillary services, good nutrition, and they don't have the florid infections that we have here, or the social and economic factors. So when we tell the parents, we tell them that these are the list of things you need to do. Your child is otherwise normal, and most of these children are very bright and intuitive about their own illness. They actually contribute to their self-care in a way that the parents never imagined they could. So finally, it comes down to a financial limitation for these medicines, nutrition supplements, enzymes. All of that takes a toll. I mean, I can tell you that averagely a patient might be spending about 35,000 or more, depending on the child is receiving IV antibiotics or nebulized tobramycin on a prophylactic basis. So you're spending a lot on that, and not to forget visits to the doctor, nutrition supplements, school, care, vaccinations. All this adds up to a lot. So financial is where the limiting factor comes in. But as in my experience, I have two patients who are older. One who is who I followed from age 15 to 25, who has finished engineering and who's working now. There's another boy who has been on oxygen before I saw him. He was 15, he's now 19. He's still on home oxygen, refuses a PEG tube, and is doing okay. I've lost one child at the age of 8 after a prolonged hospitalization for almost 6 weeks. Her sibling twin sister had died at age 3. This child lived till age 8. So the life expectation is certainly variable and unpredictable. Lung health obviously contributes to that, but financial constraints and availability of healthcare is what are the determining factors.
So my last question would be role of lung transplantation in this case, because that's something, the lung is purely damaged. I know it is not a cure, but any role of it.
Yes, lung transplantation in the West, in the US, as well as I think in the European circles, cystic fibrosis has the best outcomes for lung transplantation in the adults. That's what the transplant data says, because they have very well-paced right ventricles that are used to chronic lung infections, and so the hearts are pretty well-tuned and well-paced. So cystic fibrosis in the West, there's an algorithm for transplant where you see the survival is roughly about 50% for 5 years following transplant in an adult. There's an algorithm where they put together the FEV1, your BMI, your body weight, your PFTs, and then they see whether that algorithm predicts that you will live longer at your present state for 5 years without a transplant, or you want to accept 50% survival at 5 years. So transplant is really delayed to the point where your living 5 years is less than 50%. So you would do better with a 50% survival at 5 years with a transplant than without a transplant. Pediatric lung transplantation for CF is not really on. They did try for a while in San Francisco, where they were doing single lobe transplants from a parent to the child. But it's a very ethically debatable, because there's a 3% mortality for the transplant donor. So if you're going to take a lobe from a parent and there's a 3% mortality, and the outcomes are going to be 50% for 5 years or less, there's really no numbers for pediatrics, then the child is going to lose a caregiver possibly. So that has fallen out of favor. As the last time I have checked with Dr. Kabra at AIMS and Dr. Meenu, in India, lung transplantation in the pediatric age group has just not taken off. The adults are still working with it. The outcomes are not great because of infections and other issues. So for pediatric cystic fibrosis lung transplant, not an option until they enter the adult years. My older patient who is 25, and I'm sure with the other doctors in this group, Dr. Indu and Dr. Subramania, who have older cystic fibrosis patients, we just want them to go off for higher studies to United States or the West, where if they're in the system, they get a lung transplant and have a good outcome. Basically, a lung transplant in CF, you are trading one disease for another. You will never have Pseudomonas or your usual CF pathogens in your lungs because their internal environment is no longer there for Pseudomonas and those mucoid species, but you will be immune suppressed because the lung is a soft organ. So you'll have all the other immunosuppressive infections. So there, if you have a cough or a sputum, instead of a sputum culture, you'll probably have a bronchoscopy every time you have a lung infection. So the care after a lung transplant as well has to be very tightly tailored and monitored. But there are patients in the adult world in the West who have had one transplant, then they've gone on to even have a second transplant. So usually it's a double lung transplant and block both lungs from the trachea. And if the heart is affected as well, and these patients have been having right heart failure or they've been on chronic home oxygen therapy, heart-lung transplant. So
thank you, Dr. Samya. Thanks a lot for the information. And we wanted to ask a lot of questions, but lack of time, I would move on to the next presentation.
Sure, thank you.
Dr. Indu, I would like you to take over, share your screen and take the presentations across.
Just to add that Aster Hospital, they will be soon doing lung transplant in kids as well. Just to add to what Dr. Samya has mentioned.
Okay, that was new for me, but I think it's still probably going to be for bronchopulmonary dysplasia.
Yeah, and probably for CF as well, but not started yet. Just to add.
Yeah, I'm not sure about cystic fibrosis because if it's not being done in the West, I'm not sure that's a great option in India. I think in the West, what I have seen of lung transplantation and heart lung transplantation has been for the extreme preemies who've had chronic cystic lung disease and that kind of a patient. I've seen it for LAM. I've seen it for BPD with cystic lung diseases or other cystic malformations, but not for cystic fibrosis. So I'll be cautious in that probably.
Thank you.
Thank you. Thank you. Sure. Thanks.
Dr. Indu, you can take over.
Thank you, Dr. Samya. That was really wonderful. And Dr. Suman is a friend, and therefore he speaks only good things about us. But I need to tell you something about him. One has to learn entrepreneurship skills from Dr. Suman and how to be a great friend. I think these are qualities which are rare and exceptional, which he has. Thank you, Suman. Okay, now I will just dive straight to my cases because I think I've already given you a backdrop on sleep disorders in children. A 4-year-old with frequent nighttime awakenings. This child was put to bed at 9:30 p.m. with a regular routine, and mom stayed up with him till he fell asleep. Right, and then this child woke up 3 to 4 times in the night crying. He was comforted by his mom till he fell asleep. In fact, yesterday I had a child like this. So this child would get up, wake up, then mom will go and comfort, go back to her room. Finally, at the end of it, the mom landed up sleeping with the child in his room. No obvious evidence of snoring or snorts or gasps, no night terrors, no sleepwalking. He was just mildly snoring, which could probably be normal in a child at 4 years, where 15% of children would normally snore. He was developmentally normal, but the mom said he had mild hyperactivity in the day. So this was the history. So the question that come to us is this normal or abnormal? And how should one approach this child? So one would think that a child, a 4-year-old getting up, mom comforting, probably one would think, okay, it's fine to do that. But is it normal? Is the thought that we need as pediatricians need to start thinking. Do we need any test to diagnose a sleep study or anything else? And how do you manage such children? So before we say what is not abnormal, we should know what is normal. So what we should know is we should know the healthy sleep duration, the timing of sleep, napping, etc. in children. So if you see here, infants and toddlers would sleep for about between the age group of 4 to 12 months, should ideally sleep for 12 to 16 hours, which includes the daytime naps. But by the time the child is 1 to 2 years, they should sleep for about 11 to 14 hours. This also includes daytime naps. By the time the child is 3 to 5 years of age, the sleep duration comes down to 10 to 13 hours, including some naps. But many kids by this age have actually stopped napping. So definitely by age 5, nap is considered abnormal, and children should be able to sleep at a stretch 9, 10, 11 hours in the night and not have any daytime naps. And around 6 to 12 years of age, straight 9 to 12 hours of sleep. Children who are pre-adolescent and adolescent, 13 to 18 years, need about 8 to 10 hours of sleep. So they need quite a bit of sleep. But as we grow older, our sleep up to 7 hours is considered normal. Now, this is as per the American Academy of Sleep Medicine, which recommends that this is the healthy duration of sleep. But it has been found that sleep duration varies culturally amongst different countries. Like, so if you see the Asian population, the amount of sleep our children get is probably lesser than what the Caucasian or the Westerners get. And so there is definitely a range. And therefore, if the child falls within the range, it is perfectly all right. Now, if I go back to this child of mine, he was sleeping at correct time. So mom had started a good sleep routine by putting him to bed, but he was getting up 3 to 4 times in the night. So which is not normal for a 4-year-old. A 4-year-old can sleep through the night without a feed, without waking up, comfortably 8 to 10 hours. But truly speaking, after the age of 6 to 8 months, a child can sleep for 6 to 8 hours without taking a night feed. So mothers who are breastfeeding the kids below the age of 6 months, every 2 to 3 hourly, they breastfeed the child, right? So after that age of 6 to 8 months, they have to be instructed that now the baby need not be fed in the night. So typically there are something called as arousals. So children do have arousals because they have a higher component of REM sleep, and in REM sleep arousals are well known. So they actually get up, but they're actually not awake, and they should not be comforted by feeding, because if you comfort them by feeding, it becomes a habit for them, a prop for them to use the feeding as a prop to go back to sleep. In this case, the prop was the mother comforting the child. So this child was not being fed, but the mother was comforting the child, and the child got up for attention of the mother who would put the child to sleep. If there's something that children all the time need of parents is attention, and this is what it was the case in this case. But whenever you have a child with frequent nighttime arousals, always rule out pathological conditions, rule out a gastroesophageal reflux. This is a 4-year-old, but in a younger child, one needs to rule out reflux, which is awakening the child. You may have a colicky baby, and therefore the baby is getting up every time in the night. You need to look at allergies, eczema. So there could be children who are continuously itching, and therefore then their sleep is disturbed and they're getting up. Cow's milk protein allergy, a condition which is more well described in the West, where children will present with vomiting, irritability, and frequent awakenings. Though we do see it in our country, we see in lesser numbers as what we see in the West. We are missing our cow's milk protein allergy, and therefore we need to keep that in mind. You should also look at the neurodevelopmental aspect of the child, whether the child has any delay. So children who are neurodevelopmentally delayed, autistic kids, children with ADHD, they tend to have disturbed sleep and they keep getting up. And any chronic disease or any chronic pain or any, say, like an asthma, etc., will cause the child's night sleep to be disturbed. So we need to rule out organic causes before causing this just a condition called as chronic insomnia or behavioral insomnia of childhood. So what is behavioral insomnia of childhood? It is difficulty in initiating or maintaining sleep, or waking earlier than desired, or resisting sleep, or requiring some interventions, parental interventions, to go off to sleep. Now you have two kinds of children who sleep, the one who are called as self-soothers, and the other ones are the one who are attention seekers. The self-soother is a child who will go off to sleep on his own even if he gets up in the night. And the attention seeker is the one who would require parental intervention to go to sleep. You will diagnose chronic insomnia or behavioral insomnia of childhood is if it occurs 3 times in a week for a period of 3 months. So this is it's not like a ballpark figure that you have to wait for 3 months for a diagnosis. But if it keeps happening all the time, you should dive deep into the history of the child's parents, history of how the child sleeps and how they put the child to sleep, and then look at if there are any sleep associations, look at lack of parental limit setting. And when you can get this history, then you need to go ahead to manage Managing these children there are two ways of going about it. One is called as an unmodified extinction and the other is called as a graduated extinction, and I will come to what this is. Okay, so this is how you sleep train a child. The first step is establish a set bedtime regular schedule. So that bedtime schedule should be not more than say half an hour. So you will, maybe the child will wear his night dress, will take a shower, wear his night dress, probably wouldn't want to eat something before, maybe you should give that. If it's a younger child who takes a breastfeed, and some of these breastfeed babies would sleep on the breast, that is not a good association, because then the child in the night will get up for a breastfeeding before wanting, will take a breastfeed and then go off to sleep, and that becomes not a correct association. So if a baby is still breastfed, so the mother can breastfeed the child, later on give a shower, make them wear the clothes, maybe put the baby to bed, an older child read a book, put some light music, have a good environment to go to sleep. So this is a set bedtime routine, and the child learns to sleep on his own, because you put the child to bed when drowsy. Even if he is breastfed, to put the child to bed when the child is drowsy, pull him off the breast and put him to the bed. Keep his soft toys or whatever his favorite blanket around him, so that he can hold that and go back to sleep if he gets up in the night. So this has to be consistent. If you do it for 3 days and then don't do it for 2 days, the child will learn that there is a way around and I can escape this routine. So that is very important, that it should be consistent. Environment should be good, and put your child to bed drowsy but awake and not completely asleep. So therefore he learns to sleep. So if he gets up in the night time, he can go back to sleep. Now, children who already have a problem, so I mentioned these two things, a graduated extinction or an unmodified extinction. So here, what we told the mother was that you do not, if the child cries, you can either from day one itself, you say, hello, you may cry as much as you want, I'm not coming to your room. You keep crying. So children might throw a tantrum, may vomit, may continuously cry, may wake up the neighbors. So if the parent is instructed, if he wants to do an unmodified extinction, should not respond to the child's tantrum. So the first 3-4 days are going to be very bad. If the child vomits and messes, you just go change the child's clothes and let the child be, right? And and you must warn the parents that first 3-4 days are going to be tough. After that, if the child realizes that I'm not getting my way through, and you have to be consistent, it should not happen on the 5th day you give in. Then the child knows he can make his way out, right? So if you consistently behave like this, by the time at the end of first week, most kids are sleeping on their own. The other way is to do a graduated extinction. So you tell the child, okay, you sleep on the bed, I'm sitting here on the chair, and and sit one day for 5 minutes, the next day for 10 minutes. Reduce your reduce the amount of time that you're sitting in the room on the bed. Then you say, okay, I'm just coming back in 5 minutes, I'm coming back in 10 minutes, and slowly the child learns to sleep on his own. So this is a way in which you do a graduated extinction. Or when your child is crying, you wait for 5 minutes on the first day to go back to him. The next day you wait for 10 minutes, the third day you wait for 15 minutes, and slowly the child learns to sleep on his own. Okay, Dr. Suman, do you have any questions for this case before I go to my next case?
To complete off the cases, Dr. Indu, I would be asking all at once.
Okay, sure. My second child is a 14-year-old who had snoring since 6 to 8 months. This child had daytime lethargy and somnolence. The child had, this was recently in the COVID times, and this child had gained 10 kg in 1 year, though she was always obese, but in the 1 year she had further gained 10 kg. She used to sleep around 11 p.m. and she got up at 7 a.m. for school. She napped for 1 to 2 hours after returning from school. And that was around 2:30, 3 o'clock in the afternoon when she used to come back. She used to sleep for 2 hours. Mother used to say it's very difficult to wake her up from that nap. She was an IUGR baby, 2 kg at birth. There was a family history of obesity, hypertension, and type 2 diabetes. On examining this child, the child was hypertensive, had a blood pressure of 140/96. She had a weight of 75.8 kg with a height of just 142 centimeters. So she had a BMI of 37.5. On examination, she had a narrow oropharynx. And on Malampati score is actually a score which was used by anesthetists when they want to intubate to see the difficulty level in intubation. So there are score is from 1 to 4. Typically on score 1, you can see the full uvula, and it is well above the tongue. When it is Malampati score 2, you can see only half the uvula, the other half is buried behind the tongue. When you say score 3, you can only see the soft palate, and in score 4 you can't even see the soft palate. So therefore it basically is a measure of the narrow oropharynx. Tonsils can be also marked on sizes as if they are seen inside the pillar, or if they are seen 25% outside the pillar, up to 50%, or up to more than 50% blocking the oropharynx. So this child had a Mallampati score of 3. So that means we could only see the soft palate and we really could not see the uvula if the child opened the mouth, and the tonsils were 2+. Other systems were normal. So in this child, the question was, did this child, is the child having OSA? If at all of those OSA, what are the symptoms? So if look at here, the child had snoring and had daytime lethargy and somnolence. There was also a recent rapid weight gain. Okay, so these are, and there was the daytime lethargy and somnolence, which is seen by napping. If you remember my previous slide, I did mention that in a child of this age, there should be no daytime naps. So if the child is sleeping during daytime, this means there is excessive daytime sleepiness. So are there risk factors? Let me look at this. What are the risk factors that cause OSA, and what are the risk factors in this child was the next question that came to our mind. How do we manage, and what investigations? So I have gone through this slide in my previous presentation. When we suspect OSA, we need to ask for nighttime symptoms, daytime symptoms, and look for physical findings. So even Dr. Dindayal did mention about this: blocked nose, snoring, gas, snorts, apnea, abnormal postures, awakenings, respiratory distress or labored breathing, and nocturnal enuresis, especially secondary nocturnal enuresis. Daytime symptoms could be daytime sleepiness, hyperactivity, attention deficit, morning headaches, behavioral problems, academic deterioration, and physical findings of either the child being overweight or failure to thrive. This child was overweight. Adenoid faces, enlarged tonsils, which this child did have enlarged tonsils. High arched palate, which again this child had, and the Mallampati classification was 3. Any syndromic appearance, any craniofacial abnormalities, a loud P2 suggesting pulmonary hypertension in a long-standing OSA or systemic hypertension. But size of adenoids and tonsils poorly correlate with the severity of apnea. This we must always remember. Okay. Causes of OSA could be simple OSA in the form of simple tonsil adenoidal hypertrophy or obesity, and you have complex OSA in the form of craniofacial syndromes like Apert, Cruzon's, Pfeiffer's syndrome. You may have Down syndrome, which is very, very common, and we must remember to screen all children with Down syndrome for obstructive sleep apneas, neuromuscular disorders, and all myopathies, etc. If you pick them up early, you would prevent rapid deterioration of their respiratory system. Obesity syndromes like Prader-Willi, Bardet-Biedl, and you have other rapid onset obesities called Rohad-Net, which are late onset obesity syndromes, Pierre-Robin syndromes, achondroplasias, Beckwith-Wheatman. So all of these could be causes of OSA. In our kid, the cause was obesity. The child was IUGR, so IUGR babies tend to become more obese and they tend to have metabolic syndrome. This child also had a family history. One more risk factor in this child was enlarged tonsils and adenoids. So we took a detailed history, the approach to this child. We did a complete blood workup for metabolic syndrome, which looked at the lipid profile, uric acid, HB1AC. We did cortisol levels, we did insulin levels, right? And we also worked up for hypertension to look for any other cause, not metabolic, say a renal cause. So we looked at urine test of UN creatinine, insulin levels and cortisol levels we had already done. So we looked at all those, and we did a renal Doppler and an ultrasound abdomen to look for causes for hypertension. And then we also advised this child a polysomnography. Now this is called as a hypnogram. It might look as if some child has taken some crayons and scribbled, but let me try see if I can make it easier for you. Now, if you look here, these are flow events. The green color is hypopneas, all right? Okay, and if you see here, this child had so many hypopneas through the night. So the green going down is all this light, the light fluorescent green is all the hypopneas. The red here is your oxygen saturation, and if you see, this is 100. So many times, every time the child had a hypopnea, the oxygen saturation went below 100. So you can see all this, which is below the line here is all oxygen desaturation going below 100, and it corroborated with the hypopneas. We looked at obstructive elements in the form of movements of the chest and abdomen. So you can see here the blue things which were gone above and are all showing obstructive events, and these were the down blue are the arousals. The child got up with every obstructive event that the child had. On top here is the sleep profile. If you see that normally children go through sleep through wake, go into N1, N2 and N3, and they get a lot of N3, and they cycle between N2 and N3 before they get a REM sleep. And then the REM sleep, N3 sleep is the first half of the night, the latter half of the night, the REM predominates and the N3 becomes less. So this child's sleep pattern also was distorted. So the child did go into N1, N2, N3, then had an arousal. So when everything which went up is an arousal, then again went back to N2, N3, again had an arousal, then went to N2, N2, didn't go to N3. So the sleep was not consolidated. N3 sleep is the deep sleep which consolidates the sleep. And again here the child had an arousal, woke, again went to N2, again had arousal, went to N2, again had arousals. And if you see again N2, very small N3, N2, then had a REM here. Now this child should have had more REMs through the night. Went to N2, N3, N2, again had arousals, and really did not have much REM sleep. So as I told you earlier, REM has got mind restoration, whereas non-REM N3 has body restoration. So here towards the early morning, after 6 o'clock, the child had one big patch of REM. She should have had at least 3-4 cycles of REM. And then she went into N2, again had small REM, and that's how. So her sleep was not consolidated. So this is not a complete restful sleep. Okay. Now this is again this is what we see on the software. This is one epoch of 30 seconds. Sorry, this is an epoch of 3 minutes, not 30 seconds. Now if you, sorry, 30 seconds, sorry. This are your EEG patterns here. E1, E2 is your eye oculogram. These are your leads here, F4, F3, C4, that is frontal, central, occipital. This is your EMG. This is your pressure flow. This is your flow thermistor. Your flow thermistor shows you apneas, and pressure flow shows you hypopneas, oxygen, and the abdominal movements. The snore is here, leg movements is here, CO2 is here. Now, if you see this child, the pressure flow is almost like a flat pressure flow. Ideally, it should have been like a wave form. So this child had a low flow, and if it drops by 70%, it suggests hypopnea. Following which the child had a drop in oxygen saturation. So from 96, 95, she went down to 93, 92. Anything more than 3% is considered significant. So she had a big patch of hypopnea. She also see that she was heavily snoring here. Also, if you see all these big blue lines, which are showing the obstructive elements. So these are paradoxical movements of the thoracic and abdomen. So she clearly had obstructive events, and this was in stage N2 of sleep. Okay, so this is again which I've already described to you. This whole detailed sleep study tells me how much time she slept in the sleep lab, what was her efficiency, what was the sleep latency. It calculates how many obstructive, mixed, or central events. So apnea hypopnea index in this child was 29.8. If you remember, I said more than 1 is abnormal, and this is severe obstructive sleep apnea. This graph here tells me how much was the oxygen saturation through the night. It ranged between 90 to 100% most of the time, but sometimes it went between 80 to 90%. So our minimum saturation was 81%. So these are the detailed reports that we get. It also measures the CO2, everything, right? So this child was put on antihypertensives. You know, she was hypertensive. She was put on metformin for a metabolic syndrome. She was advised lifestyle changes. She was counseled. An ENT evaluation was done. The ENT surgeon said probably she does not require tonsilloadenoidal hypertrophy. Okay, and therefore she was managed medically first with nasal corticosteroids and Montelukast, and they said we'll follow her up. If it is still persistent, we will do a surgical removal of tonsil adenoids. So how do you manage OSA? If you have a moderate to severe OSA with AHI of more than 5, you first evaluate for tonsil adenoids. If you remember, Dr. Deendayal says first evaluate for tonsil adenoids. If there is hypertrophy and there is opacity, you first consider removing tonsil adenoids. Post-tonsil adenoid sleep study, if it's a complex OSA, there is a high risk of still being symptomatic. We need to consider CPAP or other surgical options. But if after surgery, the OSA is mild, you just need to do medical management and follow up. All right. If after mild OSA, the management should be first medical if the apnea hypopnea index is less than 5.
Indu, I'm sorry.
I can't hear you.
Sorry, I'm sorry. We are running absolutely out of time.
Okay.
I think, can we hold here?
I will just skip this case. I'm not going to go through this case. I will just finish my last 2 slides to say that children with Down syndrome need to be evaluated, because this is the commonest problem that we see. And they present to us with the variety of reasons why they can have obstructive sleep apnea. And because of the midfacial mandibular hypoplasia, they have narrow airways, they have hypotonia, they have corneal atresia, they have a large tongue, they tend to have adenoid tonsillar hypertrophy, and they may have obesity and generalized muscular hypotonia. So we should have a low threshold for screening children with Down syndrome, and 50% of children will have an abnormal pH even without symptoms. So by age 4 is what AAP recommends. And this was a child we had done screening. I will not go through the details of the report, but this child did not have obstructive sleep apnea, but this child had a periodic leg movement disorder. And there we recommend doing serum ferritin and vitamin D levels, which were low, and this child was treated and this child did well. So thank you very much. And I'm going to stop here. Yeah.
I think your last presentation was about nocturnal seizures, if I'm not mistaken. I've gone through it. It's another good case where, it is, I think I'll put you as a question itself. Children sometimes, start crying excessively at middle of the night continuously for some time with lack of consciousness. Again, they come back to sleep. Parents are quite apprehensive. Otherwise, daytime, they're absolutely fine. How do you differentiate nocturnal seizures from a, regular sleep-related problems?
So it is not easy because it looks like a confusional arousal. So child will get up crying, and the only way to differentiate it is by doing an extended montage sleep study, where we put a lot of EEG leads and we differentiate whether there's an epileptiform discharge versus just a confusional arousal. Because there is a slight clinical differentiation, because say a confusional arousal can occur only once in the night, whereas epilepsy can occur multiple times. The time, like confusional arousals occur in non-REM sleep, whereas seizures can occur at any point of time. So there are some clinical differentiation, but to cut the long story short, you need to do an extended montage sleep study to differentiate parasomnias from nocturnal epilepsy. You should have a video camera on also to help you differentiate.
And my next question is there any position of sleep for, to prevent obstructive sleep apneas? Is there any, position of sleep which you would recommend for children in general?
So what happens is, when you do a sleep study, you also see that in what state, when the child had an obstructive sleep apnea, what was the position of the child. So I just 10 days ago, I did a sleep study on a child with a myopathy. Now this child always slept on one position only, because when she slept supine, her obstructive sleep apnea increased. So if we notice in any particular child on the sleep study that a particular position is causing more apneas, we ask them to change the position. Typically, an obese child will have more apneas in a supine position because of the obesity, because of the whole decreased ventilation drive because of obesity. The apnea is worst in supine position. So we always ask them to do a right lateral or left lateral position. So it might help those children.
And are there any medications for sleep-related problems? Yes, mechanical problems, you have already suggested that, you need to treat the mechanical cause. But, if you find that, are there any medical conditions other than lifestyle change habits, changing of habits, decreasing in obesity, and surgical treatment? Any other medical treatment which you can give for a child who has got sleep-related problems?
So AHI, if it's more than 5, and it's considered mild to moderate sleep apnea, and if it is because of allergic rhinitis or adenoidal hypertrophy, one can look at nasal corticosteroids and with or without montelukast for a period of about 6 weeks to almost 3 months. And if the child responds to it, one should wait and discontinue and then follow up these kids to see how they are going. Now, children with circadian rhythm disorders, especially adolescents who sleep late and get up in the morning, first we have to try all kind of modifications by making them getting up half an hour earlier than their schedule, and slowly making them sleep half an hour earlier, then increasing physical activity, decreasing screen time, and in exposing them to light in the morning so that they get up. After doing all these things, if they are still having a circadian rhythm problem, melatonin can be tried. I need to warn people here that melatonin should not be misused. It is only after everything else has been done and they're not settling we can use melatonin. There are children with psychiatric disorders who have sleep issues, and in those children you need to refer to a psychiatrist for a lot of drugs which can be used for SSRIs, etc. There are children who have a lot of confusional arousals or sometimes lot of nightmares. After looking at all the other therapies of behavior modification, counseling, etc., some of these children do need a small dose of clonidine at bedtime to have sleep properly. Then children with movement disorders like restless leg or periodic leg movements, you should do a ferritin level. Ferritin level should be above 50. And if the ferritin is low, iron therapy definitely helps these kids. So there are a lot of medications that can be used, but they are only subsequent or secondary to having looked at all other conditions before you start medications.
So what I got from the bottom line is lifestyle modifications is one changing, and obesity, control of obesity is the second thing. As far as normal child having sleep apneas, obviously surgical causes are there, mechanical causes are there, that has to be treated over a period of time with adequate measures.
Yeah, and CPAP and BiPAP in those children with neuromuscular disorders, if medical management fails, they definitely will need benefit with CPAP and BiPAP. Neuromuscular disorders, if they are FVC, you do a lung function test. If their FVC falls below 60%, these are candidates for putting them on BiPAP. And you must do 6 monthly sleep studies in them and do spirometries in them to decide when these children should go on a BiPAP.
So Dr. Arif has a question on a lighter vein. He says, Bollywood has shown us how to sleep by singing glories. Do you recommend them?
Yes, so these are what I spoke about, those 30 minutes when you are preparing them for sleep. So you can read a book, you can sing a song, you can put light music, give the environment, have a set routine, but it should not go beyond 30 minutes. Then it becomes behavioral insomnia because you're delaying the time of onset of sleep. Now, if your child sleeps at 10 p.m. every night, the Westerners will say put the baby to bed at 7:30. If the child if you follow them, then you put the baby to bed at 8 p.m. From 8 p.m. to 10 p.m. he won't sleep. That is called again a behavioral insomnia. So for him, you put him to bed at 9:30. It's okay. It is your child who likes to sleep at 10 o'clock. So, and for that half an hour, Dr. Arif can sing a lori for the child perfectly fine.
I think I have my own strategy. Thanks to lockdown, the child has to stay in house for a longer period of time. So the only strategy which I used to use is make the child read the most boring subject which he doesn't like for at least 5 to 10 minutes. The kind of sleep my child used to have after that was tremendous. So I think, every parent has their own strategy as far as sleep, but sleep is a problem which has to be looked into. Thanks to the lifestyle which parents are having. Average sleeping time, which I ask most of the patients who come to me, is around between 11 to 12, which is quite surprising. And obviously, they have to go to school by next day 7:30. And imagine the kind of problems which the child would have at school because of the sleep problems. So thank you, Indu, for enlightening us. I would actually like to hear more, but because of the time constraints, we could not go more. Really, thanks a lot for staying here. Any other questions, please push it across. Let it be last 1 to 2 questions before I move on to the last presenter. I think we are done with questions. I think Dr. Suma Shivalan had an emergency call, so he had to leave, unfortunately. So I have Dr. Jekka, who will be presenting the last cases on functional breathing disorders, difficult cases. Then we would be closing the session. Dr. Jekka, please kindly take it.
Okay, thank you, Pawan. I'm aware that I'm between you and lunch, elaborate lunch on Sunday afternoon. So I'll not take more than 10 minutes for my 2 cases, probably even less. So because my topic was functional disorders, I had taken 2 cases where we thought they could be functional, but at the end, they turned up to something different. So my first case is, first case is a 10-year-old female child. She had a cough for 6 months, dry cough, and she's been missing school for the last 6 months because of cough, but no fever, no breathlessness or wheeze, no exercise-induced symptoms, no atopy in the child or family. The pediatrician started her on Syroflow inhaler with not much of improvement. No history of contact with TB, no symptoms suggestive of pulmonary TB. Examination, good saturation, chest is clear, no added sounds. Chest X-ray is normal. We gave some bronchodilators. There is no response to the cough. So the question was, is it a functional disorder? So I went back and asked the family, how are you using the inhaler? They said, they showed me they had a good inhaler technique. Child is compliant with treatment. So that's when I went back. This child is using inhaler very well, but still symptoms are not getting better. So it could be something else. So we took a more detailed history. So the parents told me that the cough is predominantly in the evening and nighttime and the sleep is interrupted. So this is against a functional disorder, which we discussed earlier. The symptoms in functional disorders are disappear in deep sleep. In the past, the child had 2 episodes of severe cough where the child had vomiting, headache, dizziness, and diplopia. And because of that, the child had an MRI done, and that revealed Arnold Chiari malformation type 1 with cerebellar tonsillar herniation. The child was advised surgery by neurosurgeons, but the family refused. Later, the child had a repeat MRI, and there was no worsening of symptoms. The child was managed conservatively. So now the only thing we had is this abnormal MRI with this findings. So we looked into the evidence. Can this cough be caused by Arnold-Chiari malformation? And when we looked at literature, there are cases reported in newborn as well as older children. So we discussed with our neurologist, Dr. Razia, who said that we should explore this possibility. We referred this child back to the neurosurgeons, and again the family had a wide discussion, and the child underwent surgical decompression. So as you could see in this picture, there is herniation of the tonsils into the posterior fossa, and then they decompress that. And after a few weeks of surgery, the cough disappeared. I call this child every 6 months to check how the child is doing. Cough disappeared, and child is now leading a normal life. So this was like a googly, what you call in cricket. So this is one case, and that case two, 11-year-old child, cough on and off for last 3 months. There was history of fever for 2 days at the onset of cough and no fever after that. The cough was seen only during daytime. There was no cough at night at all. A father added that the child has cough and breathlessness after exertion for 15 minutes. No atopy in the child and family. No response to asthma medication. No contact with TB. No symptoms suggestive of pulmonary TB. So in the clinic, the child had continuous dry cough. So it was like intermittent cough, like the second video of habitual cough, which I showed you. Child is not in distress. There was moderate air entry. The air entry was not brilliant, but I thought that the child was not breathing deep enough. There were no added sounds. The saturations again were not fine. So I thought, no, could it be a functional disorder? So anyway, because the child had so many, been coughing for a long time, I subjected the child to exercise. And after exertion, the child had worsening of cough. The child had worsening of breathlessness. There was suprasternal retractions, intercostal retractions. The saturations dropped from 98 to 94%. That's when I took a deeper look at this child. There's bilateral flubbing as well. Then I went back and asked the history again. The father said that for the last 1 year or so, the child had history of dryness and cracking of the skin of palms and fingers during winter and rainy season. There was some non-specific pain in both the legs, but no joint pain or swellings. So this is a child with a chronic cough, with clubbing, and also some muscle pains, and some skin changes as well. So now then the father said that, by the way, we have some investigations done in this child in the past. Would you like to see? Of course. So the father showed me this X-ray. As you could see, there is some hyperinflation bilaterally with some non-specific changes. But what is more interesting is the CT scan. I'm not sure whether you could appreciate in the slide, but this child has bilateral changes with some ground glass appearance as well, also some infiltrates as well. And this is the CT scan, which showed diffuse bilateral ground glass appearance suggestive of interstitial lung disease. This child had a bronchoscopy and a BAL, basically to rule out any infections as well as abnormal cells. That was normal. The child underwent a lung biopsy, and the lung biopsy was suggestive of interstitial lung disease. And they suggested to evaluate for autoimmune etiology as well, given the findings of the lung biopsy. The child had anti-nuclear antibodies done, and it was positive for anti-JO1 antibodies. These are one type of myositis-specific antibodies seen in inflammatory conditions like polymyositis and dermatomyositis. These antibodies are directed against antihistamine tRNA synthetase. And with these findings and these antibodies, the child has a diagnosis of antisynthetase syndrome. What is antisynthetase syndrome? It's a subgroup of inflammatory myopathies where you have myositis. Interstitial lung disease is a very known association with this condition. They have arthritis, fever, Raynaud's phenomenon, and mechanic hands. So these are the mechanic hands where you see where this child had this. This picture is not of this child, of course, but it's a different child, and this child almost had the same hands. And as I mentioned, there is a well-established association with antisynthetase antibodies and interstitial lung disease. And the child was treated with steroids and immunosuppressive drugs with good effect. So the learning points for me are always exclude functional organic causes before labeling someone as a functional disorder. A detailed history as an essential part of diagnostic process, and we have to use investigations judiciously based on history. Reconsider your diagnosis if the child is not responding to treatment. and seek help when we're not sure or confident. Thank you.
Excellent, Jekka. These rare cases, because these are the cases which we miss regularly. Obviously, we general pediatricians would have diagnosed it as functional disorders, otherwise normally thriving child, and which are not visible in a normal X-ray. I think they're quite challenging. The first case, if I could take it, Paraneomonic syndrome. Was it so significant that the father has accepted for surgery? Because I don't think parents would accept for surgery if a child is having chronic cough.
Yeah. Yes. So this child had been coughing for 6 months, and the child had been missing sleep several times, several of those days, 6 months. Child had been missing the school, and few episodes where the child was coughing, severe episodes, child was becoming dizzy and having diplopia and vomiting and other symptoms as well, CNS symptoms as well. So because of all of this combination, they agreed for the surgery.
I think that multisystemic approach by different physicians, I think that actually helped you nail the diagnosis. Otherwise, it would have been difficult for a general pediatrician sitting in his office to diagnose this case.
Yeah.
And coming to ILD, how common is it in pediatric population?
I mean, ILDs, again, they're not very common, but they're not extremely rare as well, because in the last say 2 to 3 years, we had diagnosed 4 cases of ILD. So I wouldn't say they're common. They're definitely not common. They're lesser of the less common conditions to look at pediatric respiratory conditions. But if you look at, that also depends on the place as well. So if you're looking at a super tertiary center like AIIMS or PGI, they may be seeing more cases. But for a center like us in Hyderabad, we may be seeing lesser cases as well. So we don't have any data to say how frequent it is in our country.
Thank you, Dr. Jekka. I think that would end the session. I would thank all the panelists who have been there through the day, especially senior faculty, Dr. N.K. Subramaniam, who has taken his time, and Dr. Indu, who has been through and throughout the session with us. Dr. Suma Shivalan, unfortunately, couldn't be there for the panel, but he had an excellent talk here. And Dr. Deen Dayal, despite being extremely busy, was patient enough to get his talk over. I really thank them for the sessions here. And I would hand over it to Dr. Bhaskar to take care of further, and Dr. Vamshi to take care of further proceedings. Thanks a lot for all of them for being with us. Just a minute, Vamshi, I think Dr. Bhaskar, you can make Dr. Vamshi the host so that he can give his thanks.
Yeah, it's done, Dr. Vamshi.
Dr. Vamshi, you can give yours.
Thank you, Dr. Suman. It's a fantastic. You have conducted this as a moderator and as a faculty. You have done a fantastic job, and we have a group of superb speakers and who has disseminated fantastic feast of knowledge in pulmonology, and especially each topic is excellent. Really thoroughly enjoyed. I was there from the beginning till the last, and I all the topics and this will not much time because we're already running late. Thank you all so much, KV Rao sir. You are fantastic. In the beginning, you handled so well. Only thing is we went a little over the time, but it happens because the movie is good, so everybody sat and enjoyed the feast. Thank you, Jekka sir. You are good, and Subramania sir, and Indu Kosla madam, and everyone, all the faculty. Thank you all. Have a great Sunday and week ahead. Thank you.